Good morning and welcome again. Thank you for joining us for the HIIN Virtual Learning Community. My name is Kate Carpenter and I'm the Director of Hospital Services here at the Iowa Healthcare Collaborative. Today's session has 2.5 nursing contact hours available. In order to receive nursing contact hours, you must have provided your nursing license number at registration and be logged in individually for the full duration of the learning community. You must attend all sessions to receive this credit. No partial credit will be granted. You will receive an email with a link to complete an online evaluation for today's program. Please take just a few minutes to complete that evaluation. At the end of the evaluation, you'll be able to print a certificate of attendance that can be used for all self-reporting of continuing education credits. IHC does encourage you to keep a copy of that along with today's agenda in your records for reporting purposes. Before we get started today, I want to go over just a couple of housekeeping items. Zoom is a webinar platform and there's a couple of functions we'd like you to know about. In the bottom center of your toolbar, you'll see 3 functions. The furthest to the left is the chat. You can use this function to interact with today's presenters, ask any questions that you may have, or comment on today's content. You can also highlight the raise your hand function if there's a question that you'd like our presenters to answer or you'd like us to call on you, or you can enter a specific question through the Q&A function. We'll encourage you as you're viewing today's content to go ahead and just use the chat to enter questions as you think about them. We'll make sure that all questions are moderated at the end of each session. Just a few additional instructions. Today's session will be recorded and transcribed. We'll be providing you a link with where you can access this presentation following the session. The recording and transcription along with each slide deck will be posted to Innovation. We've got a pretty full agenda for you this morning. Following our welcome, we're going to be introducing speakers from South Dakota to present on their opioid guardianship project. We're going to be overviewing IHC opioid tools. We have Dr. Afroz coming to share with us interventions to improve antibiotic timeout. We have a specialist from behavioral health at Broadlands Medical Center here in Des Moines coming to present best practices in inpatient care. We'll be providing you with an overview of the MedSurg Behavioral Health and Substance Abuse Resource Package recently developed by the Partnership for Patients Affinity Group. And then, of course, we'll be closing and leaving you with next instructions following today's session. Without further ado, it's my great pleasure to introduce our first session of the day, Opioid Guardianship in Rural South Dakota. Our presenters are Sandra and also Jennifer Koch. Sandra brings 10 years of healthcare experience to her position as Quality Director at Brookings Health System. Prior to that, she was an emergency room supervisor and a clinical nurse educator at Brookings Health and a nurse educator at Sanford Health. She is a member of the Brookings Health System Pain Management Task Force and was the key contact for their participation in the HIIN Opioid Guardianship Project. She received her master's degree in nursing education from the University of New Mexico and a bachelor's degree in nursing from South Dakota State University. This session will be moderated by Jennifer Koch, who is an improvement advisor for our South Dakota region. Welcome, Sandra and Jennifer.
Welcome, everyone. This is Jennifer Koch, and I am thrilled to be here today. And like Kate said, I am the RN Improvement Advisor for our 42 South Dakota HIIN hospitals. And it was my pleasure today to moderate a question and answer session with Sandra, who's done a ton of work at Brookings Health to combat America's opioid crisis. Sandra, tell me a little bit about your facility and your role at Brookings Health.
Well, good morning, everyone. So as my introduction said, I've been with Brookings Health now for approximately 10 years, and in rural healthcare, as many of you are, you wear many different hats and many different roles. Currently as quality quality director, we have many different departments within our department, such as infection control and risk management and peer review and all of those sorts of different things. So, and every once in a while I get to do clinical work as well. But in Brookings here, we're located about an hour north of Sioux Falls. We're on the east side of the state. Brookings Health System includes our 49-bed hospital and a 79-bed neighborhoods at Brookview Nursing Home. We also have senior living apartments, an eye clinic, and medical clinics in Arlington, White, and Volga, which are very rural clinics. We are nonprofit and we are city-owned. That offers the community a full range of inpatient, outpatient, surgical, and extended care services.
Thank you, Sandra. In healthcare, we are all pretty aware of the opioid crisis happening right now. According to the National Institute on Drug Abuse, roughly 54 million people have used prescription painkillers for non-medical reasons at least once. And furthermore, opioids are now responsible for more deaths than heroin and cocaine combined. So we're all well aware that this is a real issue and that certainly the work needs to begin in our communities. And so, Sandra, I wonder if you could give us a little background on your journey to increasing awareness on the opioid crisis that you've done at Brookings Health.
All right, so we pulled together a task force. We called it our Pain Management Task Force, and we came together back in early 2017, maybe fall of 16, and it was an interdisciplinary group. I know we had our director of pharmacy, we have nursing staff from a variety of our different service lines, same-day surgery, inpatient care, and as our ED, home health, and we had anesthesia there, and all of us were looking at and focusing on what we could do to combat the opioid epidemic. A lot of us had seen patients that were maybe misusing or overusing narcotics, and just wanting to promote other modalities and change the culture of judicious of too much prescribing of opiates, and maybe even the community mentality about what to expect in healthcare, and also the patient satisfaction piece, and making sure that patients knew that we identify their suffering and are there to help them and not just judge them as drug seekers, but what were the new evidence-based tools that we could implement to bring us to the forefront and do our part at trying to cut down on the use of opioids. And so one of the first projects we looked at, that was before I was even aware about the opioid guardianship program with the HIIN, we looked at things such as an aromatherapy program. We also, and I'll get to a few of those in the slides here in a little bit, we partnered with South Dakota State University on their SBIRT screening that we implemented in the emergency department. And we were working pretty closely with our anesthesia, doing more blocks and joint injections, things of that nature that we'd heard in the literature or read in the literature about what was working for other locations. And so that's kind of where we started. And so then when we heard with the HIIN that they were going to release, we were on the second wave of the opioid guardianship program. And I think we were one of two facilities in South Dakota that joined in with the Iowa Collaborative on this. And it was one of the first times that we've really stepped up to really embrace one of these projects that the HIIN supports. And we were very, very happy with all the tools and guidance that the HIIN had given us. And so we latched on to a number of the tools that the HIIN provided as well, just to make our program very robust.
Wonderful. So with your participation with the Compass HIIN Opioid Guardianship, what are some of the activities you help to implement in your community and at Brookings Health while participating in, I guess, post-participation?
All right, so we'll go to the next slide there. And I would say one of the easiest things or the most simple things to implement was the comfort menu. And there was a number of examples that the HIIN provided us to use the comfort menu. Different Iowa health systems had been using in different methods. And the unit that really liked this idea the most was our inpatient care, or that's our med surg, if you will. We all just have like one big floor where it's ICU, tele, swing bed, med surg, our mixture of inpatients. And so even in our quality department, we also are the lead for the patient satisfaction area. So I felt like this really worked towards those goals as well, providing comfort with our patients. And it's a concierge menu, pretty much of sorts, very like a hotel concierge menu. So the comfort menu was created to assist patients and their healthcare team to work together to reach the patient's comfort goals. We encourage the use of the menu options prior to moving to pain and anxiety medications, and we hope the comfort menu will assist in identifying comfort options that will make the patient feel confident in their treatment plan. And so the focus here is on comfort level and functionality goals versus pain level of 0 to 10 all the time. And so you'll see that when people are admitted, they don't know what they don't know, so they don't know that you have all these comfort options available to them, something simple as chapstick, eye covers, earplugs, toothbrush, all of those things, warm pack, cold pack. And so we worked very closely with our marketing department. I will say that was a huge win from the get-go, getting your marketing department on board right away, because they helped us in most steps of our project. And they were that partner that really stepped up to the plate, that kind of that happy partner that I wouldn't have expected as I was getting to starting in this project, but they really knocked it out of the park and did such a fantastic job. They even took our comfort menu and made it on legal size paper, and we laminated them. And so we have them on the bedside stand of all of our inpatient rooms, right next to, you know, like the TV guide and the menu where they can order from. And so I have seen patients look at it and talk to the nurses are great, and techs are great about discussing this with them. We didn't get it rolled out right away as quick as I wanted to, because we do have aromatherapy on there, and we had a little hold up with our med staff, wasn't so receptive to starting aromatherapy, but with persistence, we got them on board with that. So you can see a number of things that we have on this list there, and we've really had positive experiences from our feedback from our patients and their family. We'll be expanding this to our same-day surgery unit and tweaking it. And we've had discussions about that in the ER, but we're pretty good about getting people through our ER and them not having to stay for too long. So I'm not sure if we're going to implement it in our ER, but for sure it's worked really well in our acute or inpatient care area.
Wonderful. What about some evidence-based activities to help kind of combat pain management with your patient? What other types of activities did you do with those?
So the evidence, well, I'll have to have you skip ahead a few slides. We'll go to the expert slide. And there's a few other slides here about what we did with the, okay, one more slide. So this was something we did fairly early on, was called SBIRT, Screening, Brief Intervention, and Referral to Treatment. And like I said, this was in partnership with a grant from South Dakota State University and funded by SAMHSA. And it's also promoted by the Emergency Nurses Association. I'm on the board of directors for the South Dakota Emergency Nurses Association. So it was like a perfect fit to move forward with this SBIRT. It's gold standard evidence-based for emergency departments especially. And actually, the Department of Social Services in South Dakota had recently sent out a request of information about SBIRT programs for our clinics. So we are actually looking to expand our expert screening and intervention referral to treatment to our rural health clinics in White, Volga, and Arlington. So a little more about expert and what it is. So we identified, it is a training program of sorts. And so we identified super trainers and champions, and that was back in October 2017. And we attended a super trainer class that was held at the University Center in Sioux Falls on November 2nd, 2017. And it was hosted by South Dakota State's College of Pharmacy, actually. And they brought in national trainers at that time. And we are in a position where we have a few of our nursing staff are now full-time at South Dakota State and still keep PRN in the emergency department or on inpatient care. So it's great to have that partnership as well and those resources. So one of our super trainers, I was a super trainer, and then my colleague Becca, who is an instructor at South Dakota State, was a super trainer. And we trained at our facility all the ER and inpatient care nurses on March 5th and 6th of 2018. And that was a blizzard time. It always ends up being that way because we had participants from the VA and a few others that heard about our training and were planning on joining us, which I thought sounded fantastic. So what we did with our training, participants completed a 90-minute prerequisite online module prior to attending the live 4-hour course. So it was a hybrid training of sorts. We had created this expert referral to treatment guide, and it is specific to our community. We have worked really closely with what's called our Brookings Empowerment Project, and it's a branch of our Brookings NAMI, or the National Alliance of Mental Illness. And that group has created a community resource guide for mental health, and we pretty much just our marketing team did a fantastic job partnering alongside us in making it very short and concise, so it's a one-pager. So basically, when we are doing our intake or our triage of our emergency department patients, you know, you're asking height, weight, meds, surgeries, allergies, all of those things. We ask the questions. We used to just ask, do you smoke, do you drink, do you do illegal drugs, those types of things. And we expanded on those, do you smoke, do you drink, to using evidence-based tools. It's called the Audit C and then the DAST. And so you ask one question, and if they trigger on it, you ask a few more detailed questions. And so that identifies those at-risk individuals. We don't want to, the goal here is to identify people that are borderline and referring them to treatment versus those people who are full-blown deep in their addiction and trying to convince them to go to treatment. And so a lot of motivational interviewing techniques, partnering with the patients, seeing what their goals are and how we can assist them. A lot of people don't even know what one drink is. Like, hey, I like wine, like I like a glass of wine from time to time, and a lot of people don't realize that 4 ounces is a glass of wine. Or they don't realize that 12 ounces is a beer. With our serving sizes being so huge, a lot of people don't realize how many drinks they're consuming and even what binge drinking is. So it's just giving the education and partnering with that patient and engaging with that patient resources. Like before I really dove deep into this treatment guide, I had no idea that we had in our community AA meetings twice a day, 7 days a week. I mean, that was really great to hear that we had that kind of support in our community. For those of you in Iowa, our Brookings is only about 25,000 people. So we are a small community, and then we have the state's largest university. So that definitely adds to a different culture here and a different pile of resources. But I thought it was fantastic that for a small community, we have this many mental health professionals and this many resources that we can refer patients to. And we had a scripted guiding created to assist staff in motivational interviewing techniques. We use the OARS framework, you know, the affirmations and the reflective statements. We also added in documentation into our EMR to collect that, so we can go back and see how many patients were screened and what levels of how high they scored on their audit or their DAF screenings, and then how often we were giving out these treatment guides. So we're continuing to monitor that. And we do see that alcohol is triggering more often than illicit substances. But it's been eye-opening versus just us asking, do you smoke or do you drink? Yes, no, and moving on. We're going a little deeper, like how often would you say that you drink a week or month? You know, getting a little more specific. So that's the SBIRT. And then what I'll move on to talk to you a little bit more about aromatherapy. That's on the next slide. And so we've been looking at aromatherapy for a while now. Of course, we have a few of our employees that sell different types of essential oils and such. So we have a number of people who are interested in that. But we wanted to have clinical aromatherapy. And so it's the controlled use of essential oils for therapeutic and measurable health outcomes that address specific patient symptoms and enhances health and well-being. And so what we were using were inhalation sticks. They look about the size of a chapstick. And they apply an essential oil into an inhaler wick, and that goes in the middle of the chapstick, and it's kind of all combined into one inhaler there. And you instruct the patient how to inhale the essential oil as they waft it in front of their face. This way it keeps it kind of to the patient's self and not drafting down the hallway, and it's not a fire hazard like some of the wall diffusers and such. And from an infection control perspective, it was a much better option for us to use. And we use the essential oil to relieve or decrease specific symptoms to increase the well-being of the patient. There are some cautions to use in aromatherapy, and that's with pregnancy, in early pregnancy especially, hypertension, seizures, estrogen-dependent tumors, allergies, plant sensitivities, and then children under 5 years of age just because of the swallowing hazard. So we used the following essential oil types. We went with ginger, lavender, marjoram, and sweet mandarin and sweet marjoram. And so the indications for these are for pain, anxiety, and nausea symptoms. So we had to create an SOP for it first. Well, even before that, honestly, we had champions, and there was one nurse on inpatient care that was very interested, engaged in this topic, and we had another nurse in the emergency department that volunteered to be the champion for this. And so we were able to support them to go to a training in Minneapolis area where they had been running an aromatherapy program in their health system for quite some time, and they provided them with some wonderful tools. And so when they came back to us, we were able to move forward with our aromatherapy project. We created a policy. We also had to go to our value analysis team because it's a new supply and we had to order. We chose, this was a big topic of discussion, was what essential oils to use. There is a lot of different vendors out there, if you will. But we ended up going with the same vendor that this health system in Minneapolis was using for the fact that it was 100% pure essential oil, and they also had safety data sheets with their product, so that's good from healthcare regulation standpoint. They also assisted us with patient education sheets, and we created our own, which you can see on the screenshot there. And we provided staff education and physician education. And what I did the hiccups with aromatherapy that I didn't expect. I thought this would be a pretty easy slam dunk. But I called our board of nursing. There is no advisory position on aromatherapy, and I knew other health systems in our state already using aromatherapy. But actually, because there is an FDA warning about essential oils, they said it was prudent to have a doctor's order to administer aromatherapy. And I know in different healthcare facilities that this is a nurse-driven order, but there is a warning letter out there on the FDA website to, I believe it's Young Living, because of the claim that it is used to cure and treat diseases. And so they aren't FDA approved for that. And so our physicians also had a little bit of a hang up on that because they have seen aromatherapy be used rather than in conjunction with medications and traditional treatments. They see the opposite end where people go to this extreme and only use the holistic methods and do not use any of the traditional methods. And so they were quite reluctant at first, and then I did a lit review to identify all of the benefits, and our compromise was having on the top of the patient education sheet there that FDA warning, or essentially that they're not intended to diagnose, treat, cure, or prevent disease, but it's used to palliate symptoms. And then they were happy with that and were able to sign on to that. If you go to the next slide, this is the research study that was from Allina Health. And their sample size, I'm always impressed with research studies with that huge of a sample size, 10,262 patients across 10 health systems in Minnesota and Wisconsin. And they were seeing market effects of using aromatherapy with those 4 that we decided to launch there. And so, like you can see, lavender works really well. Lavender and sweet marjoram for pain, and you'll see that the lavender and sweet marjoram work really well for anxiety, that the ginger works the best for nausea. Cost for the inhaler was $315 an inhaler, and they're pre-made inhalers. They're a non-chargeable item to the patient. The patient takes it home with them at discharge. And the manufacturer we use, I have no conflict of interest, by the way, but just for those that are looking, we use Plant Extracts International. And they're the ones that give us the safety data sheets. They said with this study that it reduced cost of care by $800 to $900 because of length of stay. So we also created EMR charting and reassessments of symptoms in 30 minutes. And we're going to be expanding this as well. We're already using it in our same-day surgery area, but we've had discussions about long-term care, home health, and hospice. And in our OB area, they don't use the inhalers, they use the diffusers, but that was a little bit different conversation having with our infection control about the rules about using the diffusers. But it's been, some patients really, really love it and some want nothing to do with it. So it's just very individualized. Some patients really hate certain scents. So we've seen benefit from using the aromatherapy program. The other thing, evidence-based, not that on the next slide there, is the ALTO program, or Alternatives to Opioids. And I heard about this at the Emergency Nurses Conference in about almost 3 years ago now. Dr. LaPietra from St. Joseph's Medical Center in St. Patterson, New Jersey presented on this. And I just thought what they were doing in New Jersey was absolutely amazing, and that they've had the resources to support this in their emergency department and did really well. So back in January of 2016, they started with 500 patients treated via ALTO. And for ALTO, it's alternative to opioids. And the big things that they talked about were using like nitrous oxide or laughing gas more so. And that had worked pretty well for some of our wound closures with our PEDS patients. She talked a lot about using lidocaine for IV lidocaine for our kidney stone patients. They talked about using IV Tylenol. They talked about using ketamine for some of those headache patients. And I will tell you that we did not get buy-in from our providers on all of these. I would say we did have an increase in our use of nitrous oxide with mixed results, and we have used ketamine in certain instances with our migraine patients, but we did not get our pharmacist to buy on for the IV Tylenol due to expense, and we did not get our providers. We're a little skeptical about the IV lidocaine for our kidney stone patients. But back to the research, the Alto research by Dr. LaPietra, she says that they reduced their opioid use in their emergency department by 38%, and about 3/4 of their efforts were successful. And Dr. LaPietra made the comment that so much pain is tied up with fear, and we can do more than we think we can if we just take the time to sit with patients and let them know that we're present for them and we're here for them. And so I thought that was an easy win coming from her presentation, but worth investigating. And also the other thing that we took from this Alto was doing those joint blocks and using more anesthesia on the outpatient side of things. So this one was mildly embraced with us, but maybe in your organization with the research that's out there, it's worth investigating.
Thank you, Sandra. Let's circle back, and why don't you tell me a little bit about the prescription drug monitoring program and its use at Brookings?
Okay, so that is on like a few other slides before that. Sorry about that.
Slide 4. Sorry.
Okay, so this was with the Compass HIIN. They've talked, I think they had one webinar specifically devoted to the PDMP. And it was very interesting when listening to the HIIN presenters, the differences between Iowa and South Dakota. So I did a little legwork and connected with the Board of Pharmacy, just backing up a little bit what the PDMP is to improve patient care by providing prescribers and pharmacists with a controlled substance dispensing history for their patients. An additional goal is to reduce drug diversion and inappropriate use of controlled substances by assisting in the investigation of the specific cases. So we discussed EMR changes for providers to document by clicking a box in the patient's chart when they check the PDMP prior to prescribing opioids. In our state, it is mandatory for licensed healthcare providers to be on the PDMP, like have their login, but it is not currently mandated that they need to go in there and check it before they're going to prescribe opioids. And so when I was speaking with the lead at the Department of Pharmacy for this, asking if questions such as if we can get data on how the usage specific to our facility or anything like that, and they've been pretty tightly kept. They said the only people that get the data are the prescribers themselves. They can go in and run a report on how many times they've checked the PDMP or such. And then they have up to 5 others, their designated affiliates is the wording that they use, that can check their PDMP for them. And I know we also have a PPB clinic that we are with, the Vera Brookings Clinic. And in talking with our physician champion, he said oftentimes his nurse he'll ask the nurse to go in and check the PDMP before he prescribes opiates. And so for us on the admin side of things, or the data girls, we like to, we talked about that EMR change. So we're still trying to get the docs we're still working on the build in our EMR to get that box checked and the workflow for that. And I did go with our clinic side of things, we are knocking it out of the park. So we did physician education, and we did this to the emergency department, medical committee, as well as the med exec community. And all the providers were already aware of this. Many verbalized that they use this, but it wasn't consistent on when they do. They just kind of used their gut feeling about when they wanted to, or if something didn't seem right, or they didn't have a specific protocol for how often or how frequently they check the PDMP, but all of them had said that they use the PDMP. And if you go on the Board of Pharmacy's website, you can get this high-level data about the number of prescriptions that are prescribed. And you'll see that even dentists are on the PDMP. And then when we had our opioid guardianship forum, our veterinarians said that they are not required to be on the PDMP, but you'll see a number of professionals that are. And then that ties really closely, in my mind, to electronic prescribing, which they talked about in the HIIN. And if you go to the next, that's our fingerprint that's connected to our laptop there, and that's in our ER, and that's where our prescribers, we have the ability to e-scribe, and I will tell you that we are doing really well in some specialties, and we are doing not so hot in others, and we have our early adapters, and we have our laggards that really just are probably not going to do it until they're absolutely mandated to have to do it. But I will tell you that e-scribing goes hand in hand with CMS's promoting interoperability requirements. And the focus here has been in the past on primary care providers using this technology. Where we see our gaps would be in our ED, and then when our surgeons come over from the clinic and have surgeries when they're discharging them, we're still seeing some handwritten prescriptions. And so we worked very closely with our IT to onboard our rural health clinics and making sure that they're using the e-prescribing technology. And our emergency physicians, they were encouraged to increase their e-prescribing rates during the emergency department medical committee meeting on June 1st in 2018. And we have data per physician, a dashboard. They kind of have a love-hate relationship when they have to see their name compared to their peers, but we kind of use that as a carrot and the stick approach to get a few others to join in on with their colleagues in using this technology. And so for Q1 of 2018, for example, our PPB clinic had a 94.7% prescriptions were e-prescribed. And we have work to do on our surgery side and our ER side, but our primary care, and including our rural health clinics, as well as our hospitalists, are doing really, really well with this e-prescribing. And I did use the story of we've had times of when patients have tried to alter prescriptions, instead of saying that they were going to get number 10 of Norco, they've tried to alter it to 40. And that topic came up during our opioid community forum. And so doing the electronic prescribing takes out the middleman. And from a patient satisfaction point of things, when you can essentially, quote unquote, call in their prescription for them while they're still in the emergency department and they don't have to walk that prescription over there, it's a benefit, as well as for tracking and handwriting. Sometimes providers' handwriting is atrocious and then mistakes can be made. So there are so many benefits of e-prescribing, and I'll talk a little bit more about, I have heard that Walmart is going to go to strictly e-prescribing in 2020. So using that bit of news clipping and information for our providers, trying to get them on board early on. And I know I have on my last slide here that there's some federal legislation coming down the pipe about e-prescribing. So more to come on that. And I think that before too long, it's going to be handwritten prescriptions are going to be extinct. Another thing we did with our HIIN program was really promote our National Drug Take Back Day. And that's Officer DeYoung there at our Sheriff's Department near the jail. And we partnered with our Sheriff's Department because law enforcement can be the only ones that do the drug take-back days. Those happen twice a year, once in April and usually once in October. And so what we do, again, partnering with marketing on our social media and our press releases, letting the public know that we're having our national take-back days. And so that is our teeny tiny box right there. And our sheriff says that fills up almost daily. So that's in our next steps as well, is getting more drug disposal boxes. And we've been working on getting those opioids out of the communities, out of medicine cabinets, and destructing them properly so they can't be sold. We also, very similar to this, have been working with the HIIN and using our Narcan monitoring of adverse drug events. So I share that data with our board of trustees and with our partners of how often we're using Narcan in the community as well as in our emergency department. And I'm currently working with the DEA and community partners on more drug disposal programs, which is actually a little bit different than a take-back program.
Thank you, Sandra. Well, we are getting to the end of our time, but we definitely want to hear a little bit about your story. You had what I guess we could all agree was a very successful opioid community forum in Brookings that you hosted. And so could you tell us a little bit about that meeting and the impact that you think it had on your community in creating awareness about the opioid crisis?
Absolutely. So this, the community forum, that idea was generated from the HIIN Opioid Guardianship project, where we learned that a number of rural communities in Iowa were reaping benefits of holding a community meeting to discuss the opioid epidemic and providing the community with resources to combat the issue. So the purpose of the community forum was to reframe pain to focus on comfort and functionality and create a culture of judicious opioid prescribing. Our community-wide forum hosted a variety of professional panelists. We had law enforcement, a mental health counselor, a dentist, a veterinarian, a retail pharmacist, our state's attorney, a primary care physician, and even an officer from our DCI area. And our primary physician that was there, he also serves as our coroner. So that was an interesting perspective, and he's been our physician champion on all of these projects. And once again, marketing hit it out of the park, and you'll see there our flyer on the left there for our forum. And then we did a lot of radio ads. So there I am taking a selfie with our state's attorney there, Terry Nesvold, and we went to 5 different radio stations and promoted it to the public. There was a press release, we had the flyers, we also were on a radio show called the Prairie Doc Radio Show that a lot of people in the community highly respect. One of our physicians, Dr. Holm, and so he has a radio and a TV show, so we were able to be on that. Terry and I joke that we should be like the Gail and Oprah and have our own radio show now that we've done that so many times for talking about opioids. We also did some Facebook videos. We had talked about upstream prevention. So we had Dr. Heeb talking about the PDMP and electronic prescribing. We did a treatment video where we had one of our mental health counselors kind of talking about basically the resources that are on that referral to treatment flyer. And then we had one of our law enforcement officers talking about medication disposals and the take back and getting those meds out of the cabinets, and those were well received. At attendance at our forum, we had 46 participants at our noon session, and we had 17 participants at our 7 p.m. session, and then it was recorded, and we had that on our YouTube channel. Our marketing uploaded it to that, and our handouts were provided during the forum. There was a substance abuse referral to treatment guide, as well as all the disposal sites statewide, and we put those on our brookingshealth.org/pharmacy webpage, and they're still up there. And here was our data about our Facebook videos and who all watched those. We had overall 5,564 people look at our videos that we had, and you can see more women than men, but we really reached that young group, that 25 to 34 age range. And so I thought it was pretty cool with Google Analytics that they even have that data to show you. But I think it was such a win how we leveraged technology to promote our opioid forum. If you go on the next slide, there's Dr. Heeb and Dr. Jill Ayers. She's our veterinarian, and then Dr. Heeb in the blue shirt there. He's our primary care physician, our physician champion, and the county coroner. We also had great administrative support. Our CNO signed on to be the administrative champion, and she attended a number of the webinars and planning meetings. She checked in on the progress almost weekly, and she attended the noon session of our opioid forum and the medical committees when the aromatherapy, PDMP, and e-prescribing when they were discussed. Our CEO supported the opioid forum. He attended the 7 p.m. community meeting, and they also took on the cost of refreshments for the community forum. We used the city county government building, so that was free to us. So we put on this community forum at like little to no cost. Mostly it was just a little of the man hours involved. We also had a moderator, a faculty member from SDSU, served as a moderator for our panel. Audience attendees self-identified as concerned community members, concerned family members of loved ones with addiction, as well as workers from DSS and a variety of professionals from the university. And so that was really successful. We have federal legislation coming down the pipe. If you hadn't heard, the SUPPORT Act was signed in the end of October by President Trump there. And so you'll see there's going to be funding for ALTO, the MAT, PDMP, law enforcement and foreign shipments, fighting fentanyl, and Medicaid funding for opioid use disorder and addiction. And I believe there's some telehealth in there as well. And then one that is not quite as far in the legislative process is the Every Prescription Conveyed Securely Act, and that's going to be the mandatory electronic prescribing for controlled substances. In previous legislative years that have tied into it was the 21st Century Cures Act and then the Comprehensive Addiction and Recovery Act. So we're seeing quite a bit happening at the federal level and the state level. And I think, to quote the words of our state's attorney used during our radio promo and the opioid forum, she said, "If we save one life, we have been successful." And though it's difficult to quantify our successes, we strongly believe that we will hear stories of those we care for in this community, or perhaps the professionals that we form relationships during our planning and implementation stage of improvement. Our group takes pride in knowing that the amount of medications being disposed of at the drug take-back site at the sheriff's office, and we believe we were successful in creating awareness and providing resources to our community. However, we have continued progress to make. For example, one of our ER physicians continues to refuse to e-scribe, so we hope that we can influence his habits. Also, with the expert in aromatherapy being newer programs, we continue to educate new staff on these topics and reinforce key principles. And I would say a challenge to this would be time. So many competing priorities in a workday. It's hard to get teams together to focus efforts. And it gets increasingly challenging when coordinating efforts with external stakeholders. It takes resolve and commitment to follow through on worthwhile projects such as these. And money and budget's also always a concern. So for each intervention, one must consider the return on investment and value added impact. This project fell into our laps, and we did not have these interventions included within our budget planning last year, but we made it work. We ran into a little bit of a setback with the aromatherapy. The providers feared plant allergies, airway reactions, and refuting medical advice in lieu of holistic methods. But again, we did that lit review and provided continuing medical education, and we resubmitted our proposal, and they accepted our proposal with a few edits and conditions. So looking back, we wish we would have worked harder to recruit Dr. Heeb, our physician champion, from the get-go with our pain management task force. We didn't expect to get pushback in the aromatherapy program, and I feel like his influence may encourage his peers to use the PDMP, e-prescribing, and aromatherapy. And so we're lucky to be able to recruit a family physician county coroner to sit on our panel, but a physician champion would have been helpful in our implementation endeavors. So ask for suggestions for other facilities. Don't be afraid to have these difficult conversations within your communities. There was some initial concern that a disgruntled community member would attend our forum, but that was never the case. And then please continue to add adverse medication event data to the HIIN database for benchmarking, and use those opioid guardianship tools provided for on innovation, and reach out to Lana and Sarah from IHC for additional expert consultation. They were really helpful in the success of this project.
Sandra, it's Kate at IHC, and I just want to express our gratitude for the work that you've all done in South Dakota and in your community specifically. I think those that are on the line and listening have learned from your wealth of knowledge, expertise, and certainly from your experiences, so thanks for sharing those. I know we are at time, but there's been several questions entered in through the chat, and so Sandra, if you're willing, we'll just try and get through at least a few of those quickly, and then we'll respond to the remainder of the questions through our follow-up email following today's learning community. The first question is, was your opioid project nurse-led, ? And how did your nurses implement the training or change how they talk to patients?
So I would say that it was interdisciplinary, but I was the key point person, and then as a nurse background, quality professional, whatever hat you want me to put on that day. But I couldn't do it all alone. Our director of pharmacy, he played a part in this as well. Our director, who was also a nurse of our ER, was essential. And then again, Dr. Heeb, and then in the community efforts, our state's attorney. I couldn't have asked for a better partner. It seems a little intimidating, but at first thinking, oh my goodness, I'm going to be partnering with our state's attorney. But I'm really grateful to have that partnership with her. And I look forward to working on other projects with her in the community. And how did it change? I would say that, you know, motivational interviewing's been out there a while, but really hitting home with scripting for our nurses with the motivational interviewing has been one of the best. And then in order to hardwire, you have to do those spot checks and be listening on how those conversations are had. You know, so if that comfort menu is just kind of thrown off in the corner and not ever gone over with the patient, of course, they're not going to get the full benefit of using it. So it's really getting the buy-in from those bedside staff, and then using those motivational interviewing techniques. And of course, we have some that are knocking it out of the park and some that are laggards on that, just like any improvement or change process.
Thanks, Sandra. Next question is, what's the name of the audit tool for CBERT?
For SBERT, so the alcohol one is called Audit C, and the drug is called the DAST, D-A-S-T. And if you Google SBERT, you'll see those tools out there. There's a lot of funding with SAMHSA on diving a little deeper with SBERT. I believe there's even some tools on the ENA website, but I'm not sure if those are locked down to the members or if those are freely available. I think just like with the NIH stroke scale score and how that's going into risk adjustment, I could foresee the government using SBERT scoring in quality programs, whether it be risk adjustment, or I know they're looking at using some opioid measures in the future. So having a little foresight ahead of time and getting on the ball with the SBERT, I think is a fantastic project.
Thank you. Just one last question, and then I assure you all we'll have Sandra respond to the rest of these questions either via the chat or via email, and we'll send those out. Sandra, the next question is, would you be willing to share where you're purchasing oils from, what your source is, and would you be willing to share your policy related to essential oils?
Yep, no problem. I can send that to the HIIN there. Sorry, I have to rustle my papers and get back to my aromatherapy slide. But we use, one more time, and again, no conflict of interest, but there was a lot of discussion if we were going to use Young Living or doTERRA or medical grade, and we ended up going with the Plant Extracts International Inc. And mainly because of the research study that Allina Health had used with that, and that was the slide that had the sample size of 10,000 patients. We have enjoyed using them as our supplier, and I can send whatever information that I can send that to the HIIN, no problem. Same with our policy.
Absolutely. Thank you so much, Sandra, for being willing to share those resources. Again, to our audience attending the session today, we'll include those in the follow-up materials. At this time, I know we're a little bit behind schedule, but we'll make up the time. We're going to transition over to our next session on the IHC opioid tool. Presenting this session is Sarah Durr and Lana Comstock from the Compass HIIN team. Sarah Durr serves as the Director for Medication Safety and Effectiveness at the Iowa Healthcare Collaborative, contributing to all operations and initiatives aimed at medication safety and effectiveness in healthcare. She has an array of experiences across the healthcare spectrum, including long-term care, inpatient, ambulatory care, toxicology, policy, and advocacy. She completed her PharmD at the University of Minnesota College of Pharmacy and an ambulatory care residency at Fairview Health Services through the University of Minnesota. Dr. Durr serves as the inaugural Executive Fellow at the Iowa Pharmacy Association, where she was engaged in patient care initiatives, clinical expansion initiatives, policy and advocacy efforts, and advancing the profession of pharmacy in Iowa. She's joined by Lana Comstock, whom is a clinical quality consultant for the Compass HIIN here at IHC. Lana has a master's degree in nursing education and primary nursing experience in home care, long-term care, and paralegal nursing. She is a nursing administrator focused on nursing management, nursing education, and organizational quality. Her practice always being inclusive of patient and family engagement. Lana's experience within the HIIN includes facilitation of the Falls Prevention Community of Practice, Opioid Guardianship Project, and serving as a consultant to all hospitals in Iowa, Illinois, and South Dakota. At this time, I'd like to welcome Sarah and Lana and pass the floor to them. Thanks for joining.
Thank you, Kate, and thank you for having us to give this update on our current tools that we have available through the Iowa Healthcare Collaborative. We just wanted to give an update kind of on where we're at and different toolkits and guides that we now have available to you. And these are available on both the Compass HIIN on our innovation area or on our website, and we'll have websites available for you as we go through these slides. So as a reminder, IHC is working hard on combating the opioid crisis through three main pillars. First and foremost, upstream prevention and appropriate prescribing. And that's where our Opioid Guardianship Project has really focused over the last year and a half or so. The second thing that we're looking at is addiction treatment and relapse prevention, and this has become more prominent in the second half of 2018 and will continue to be a focus for us in 2019 as we look to increase the number of medication-assisted treatment sites, not only in Iowa, but in the other states that we serve as well. And then lastly, sprinkled throughout both our Opioid Guardianship Project and in our work with addiction treatment and relapse prevention, we've had some work around diversion prevention, not only in the community, but also in the healthcare setting. And then also looking at medication disposal so that we do get these medications out of the houses and off the streets. Next slide. So this probably looks familiar to most of you. You've probably heard us speak on this a couple of times. This is our IHC Comfort Scale. And like the previous presenter shared, this really is meant to reframe pain to talk about comfort and functionality so that we are looking at it from a more positive light. It's called balance framing. And this has been really successful in the about 60 hospitals that we've worked with in South Dakota, Iowa, and Illinois. And we have now had the American Hospital Association also approach us to begin using some of these resources in their 1,600 or so hospitals that they serve. And as you can see, the website to access this is at the bottom of the slide. I will note that when you do go to this website, you do need to sign a memorandum of understanding or terms of use. And this is more so for us to make sure that we can give you most up-to-date information if these resources have any changes, and for you to give us feedback on these resources so that we can continue to improve them as we continue to use them. Next slide, please. So this is our comfort menu. We have kind of adjusted these over the last year and a half or so. We have an inpatient version, which was very close to our initial version, that has options that you may have available in your hospital or in another inpatient setting. And these are all completely customizable. So if there's something your hospital does not offer, you can change that. We do have the medication section that we worked hard to work on our wording and making sure that our verbiage made sense there. So that's one section that we ask that you only really change the area on the third bullet point that talks through different alternative medications available in case you don't have things like IV Tylenol available in your hospital. Next slide. And then we do have an outpatient version, and this came about from working with our hospitals as they started to go into their communities and seeing that we really needed something for the patients to not only take home with them, they can take the inpatient version home, but the outpatient version really offers them some things that make more sense at home. It's more so talking about regular personal hygiene, talking about repositioning, looking even at that middle section on comfort actions. Do you need Meals on Wheels? Is transportation necessary? So looking more at that larger picture when a patient does go home and into the community and what their needs may be. Next slide. And then finally, we have our comfort treatment plan. We do have this now for both acute conditions and chronic conditions. The only difference is that top box or that top table in our time frame. So on acute, we'd look at 8 hours, a full day, 3 days, 7 days, 2 weeks. Whereas for acute or for chronic conditions, we are looking at 3 months, 6 months, 9 months, 12 months, and then beyond a year. Otherwise, our scale is there for reference. We have an area to write down anything that worked well for the patient while they were in the hospital, some questions that they can ask, because we know that they do not always know what to ask their providers, and then their primary care information and when to call 911. And next slide, and I'll pass it off to Lana.
Thank you, Sarah. When Sandra spoke earlier, we heard her talk a lot about engaging the patient and their comfort level. And one of the main things in working with the comfort tools through IHC is just that we are really person and family centered. When we take a look at each of the tools, we can start to think about the patient and their comfort level and really engage the patient. What this does is helps to provide that action plan when they're going to transition home. It also helps with the families or significant others of the patient to really know what it is that works for each patient. So when they do transition home or even to long-term care or other home care, they will be able to still utilize those tools. The comfort menu is one of the best tools to help with that transition. So we really want to stay focused on patient and family with all of our tools, and we think that those do that. The other thing, for instance, when we took a look at the treatment plan, that oftentimes sparks many conversations from patient and families. We encourage that people take that home and that the patient on return appointments takes the treatment plan for further conversation with their provider in the clinic setting. So the tools have been instrumental not only in the hospital, but also in the clinics and for home care. One of the other tools that we have are the opioid resource guides. These have been prepared by county now. And what's really nice about this is that these can be posted in your emergency department. We're finding that it's a helpful tool posted there. It sparks conversation. What it looks at are the drop-off sites for medications. It looks at treatment facilities that are located within the county, any standing naloxone orders and where those are. So these are really nice tools to use to prompt those conversations. I'm also finding in working with hospitals that when these are sent home with patients who are prescribed opioids, that they actually have it available for themselves and or their families to remember where to take unused prescriptions. So that's a huge benefit. And it has also, as I said earlier, prompted many conversations with patients and families. You can look at the opioid resource guides again on our website under the community resource tab, and then under opioid flyers, and they are placed there by county. One new tool that we are getting ready to forward out is called the Opioid Stewardship Implementation Guide. This guide has been developed through our works with the Opioid Guardianship projects. And what's really nice about it is we're going to have some links in there for the webinars that we utilize during our projects. We also have some indicators in there for some things that we had through our learning through the project. So some best practice tips will be included in that. And ultimately, our guide is really about forming that team-based strategy in how to move forward with developing an opioid stewardship guide and program in your hospital. And Sarah, could you talk about your new tool?
Thanks, Lana. IHC has been really hard at work with multiple state partners across the state of Iowa to develop a pain management toolkit. This is specific to Iowa's Guide to Opioid Stewardship. However, the most Iowa-specific information in here is focused around more so rules and regulations. So there's still a lot of great information that you can access via the link at the bottom of the slide here. And next slide. And this just shows the table of contents. I think some of the highlights in here are really the art of difficult conversations. These are not easy conversations to have with providers or with patients, but there's a lot of good tips and tricks on how to have those conversations in that section. We also have information on non-opioid treatment, and then it looks at acute, subacute, and chronic pain, as well as discussing some tapering strategies and how to go about that. There's also information on benzodiazepines and the use of those within the guide, so there's a lot of great information. And then it is about 150 pages or so, but 75 of that is just the different resources that you can utilize, such as the Expert tool and some other tools out there that are available. Next slide. And then lastly, as I mentioned, we do have the websites listed on each of the slides. However, if you go to our ihconline.org, if you click on community resources at the very bottom there, you can find the opioid flyers that were mentioned, and then also our IHC Comfort resources is where our toolkit for Iowa will be available. And Lana and I are working really hard to get that stewardship guide available to you all as soon as we possibly can. And thank you all for your time and for utilizing these resources. It's very exciting, the work that we are doing, not only in Iowa, but now spreading nationally. As always, Lana and I are available to you if you have any questions or if you want to talk through anything, feel free to reach out. Our emails are on the slide, and we're happy to take any questions.
Thank you so much, both Sarah and Lana, for presenting those resources. We know that those are and will continue to be valuable resources to hospitals across the nation. Please do reach out to both Sarah or Lana. Their contact information is located in the slide deck and on your screen now. At this time, we're going to transition to our next session. The next session is on interventions to improve antibiotic use, specifically antibiotic timeout. It is my pleasure to introduce our speaker for this session, Dr. Afroz. She is an infectious disease consultant with CIC Associates, and she's a board-certified internal medicine and infectious diseases doc certified in travel health and credentialed HIV specialist by the American Academy of HIV Medicine. Her special interests include antimicrobial stewardship, travel and tropical medicine, transplant infectious diseases, infections and immunocompromised patients, HIV and AIDS, global health, and hospital epidemiology. Dr. Afroz has practiced at Mercy Medical Center for 10 years and is the director of the Antimicrobial Stewardship Program. She's also the president-elect of the Mercy Medical staff. She is faculty and mentor to residents at Mercy Des Moines University and is an adjunct assistant professor of internal medicine at DMU. Please help me in welcoming Dr. Afroz. Thanks for being here. Dr. Frost, go ahead and unmute your phone line. We're ready for your presentation. Thank you.
Hello there.
Hello there, we can hear you. Go ahead, thank you.
All right, thank you very much for the introduction, and thank you everybody for attending this session. I was a little bit nervous about the topic because it's such a narrow topic in my whole antimicrobial stewardship world, but I hope I can justify at least pointing out some core things regarding antibiotic timeout. So our objectives for today are to understand the purpose of antibiotic timeout and what elements should we be including in here. We have to identify the barriers in implementation of a process in our particular facilities and discuss the importance of multidisciplinary team approach and how can we make our policies and protocols a success. We also will review some suggestions, some methods to formalize the timeout process in hospital settings and review some ideas and resources. It's at this time I would, in the end would welcome some sharing of ideas and sharing of resources and experiences. And we'll talk a little bit about, in the end, about the CDC core element number 4, which is action. So let's start with some introduction. We all know that there are 30 to 50% of antibiotics prescribed in hospitals are inappropriate. We have several studies supporting this statement. There is a constant misuse and overuse of antibiotics, not just in our hospitals, but even in outpatient settings. There are many problems that a stewardship physician and pharmacist and the whole team has to tackle. Broad spectrum antimicrobials that are being continued for several days. Patient might be on the wrong antibiotic. There is a bug and drug mismatch, and people might be using inappropriate doses. Most of the time we see in obese patients, they are on a lower dose. And longer durations without addressing, do we really need to continue these antibiotics? Next slide, please. So these are the core elements of hospital antimicrobial stewardship program, and this is from CDC. We have to justify all these elements in a stewardship program. There has to be a leadership commitment, a pharmacy leader, a physician leader, accountability. People should be accountable for actions, policies, and protocols that we create. There has to be some form of drug expertise, and I am fortunate to have infectious disease pharmacists around me, and so sometimes people don't have that, but I would say anybody interested in antimicrobials can become, a part of stewardship team. The fourth element is what we're going to tackle: action, implementing certain policies. Tracking and reporting is very important when it comes to reporting to administrative people. They always like graphs and, want to see the progress, how we are making. Education, the last element, is really very important part of stewardship program too. Next slide, please. So antibiotic timeout, the key thing here is that we have to make sure that antibiotics are used appropriately. So antibiotics, when a patient gets admitted, small or bigger facilities, we try to go big with a broad spectrum antibiotic, and that is our empiric treatment. Now, we as stewards don't jump on this thing right away because at that time we do not have much of data to de-escalate antibiotics or really justify that somebody shouldn't be using it. Providers, when they start broad spectrum antibiotics, they sort of forget or just do not revisit the prescribed antibiotics after more data is available. And providers should perform a review of antibiotics 48 to 72% after they are initiated. So core element number 4 is action, where stewardship programs should implement at least one or more interventions to improve antimicrobial use in hospital. One such recommendation is the antibiotic timeout that we will be talking a bit more in detail, wherein the antimicrobials are evaluated after a set period of time, and you can set that period based on your resources and however your EMR is going to support you, or if you're going to review charts, what is the appropriate time that you can review those charts. Next slide, please. So this term is used by CDC, and as I mentioned, that the key intervention is improving antibiotic use. People have tried different ways, prompts to providers to evaluate and assess the continuing need and choice of antibiotics when diagnostic tests are available and lab data is available. And it's a stepwise reassessment. So when I say antibiotic timeout, doesn't really mean it is 48 to 72 hours. Things have to be reevaluated down the line also. If you don't make changes in 48 to 72 hours, then you can highlight your charts that you have to get back to them again. Next slide, please. So our purpose is to learn how to develop a process for these timeouts. And education, again, is very, very important when we introduce any policy. And the stewardship team usually has to communicate with hospital-wide providers when they implement something. So people are aware of what changes they have to make in their day-to-day activity. Physician leaders should integrate regular antibiotic reassessment in their own practice. And you have to be leaders so that patients, not patients, but your colleagues or pharmacists, they can look upon you and you will encourage other people. So implementation recommended by CDC and several other public health departments campaigning about our antibiotic timeouts. You can also set up some reminders, possibly stickers in EMR or some form of notification to the provider that it's about time that they look into antibiotic de-escalation. You can have some pop-up alerts in there. Or if your facility is smaller and you don't have much providers and you don't have many people on antibiotics, then perhaps it can be a face-to-face conversation between pharmacist and physician or a phone call to address this issue. Stewardship team is definitely responsible for auditing and assessing the compliance of a process and providing feedback. Next slide, please. So the key principle, as an infectious disease physician, my goal is always to treat an infection and to educate people to treat only when needed. We don't like to treat colonization because not every culture needs to be treated. We have to assess, is this trait colonized with the Pseudomonas? There is no pneumonia in a chest x-ray, really doesn't need any treatment. Is this blood culture contaminated? I mean, do I have to treat staph epidermidis in the blood? So those are the questions you have to think about. Pathogen-directed therapy is our main goal. Again, we have to determine if it is a pathogen that's causing problems. We have to resolve bug and drug mismatches. So if you have somebody has a culture of Pseudomonas and you have a drug that doesn't cover Pseudomonas, and there things to have to be resolved as soon as possible. And also our goal is to eliminate redundant coverage. More so at this time with the increasing C. diff rates everywhere, my goal is to reduce anaerobic coverage as much as possible. So since vancomycin zosyn is everybody's favorite, I teach residents and other faculty to think about, do the people need anaerobic coverage? Why vancomycin and zosyn? Can we go to vancomycin and cefepime for some of the diagnosis? Definitely sometimes zosyn is needed, but not all the time. Next slide, please. And our assessment, continued assessment would be, okay, can antibiotic be stopped if we have an alternate diagnosis, such as influenza or pulmonary edema? And we have to optimize dosing. As I mentioned, obese patients are often dosed, not dosed according to their weight. We have to look into renal insufficiency and make appropriate dosing changes. And our goal is to de-escalate antibiotic. Switch from IV to oral. Many facilities have gone to this, especially oral agents that have 100% bioavailability in the serum. You can safely switch them to oral agent. Levaquin doesn't have to be given IV all the time. If patient is eating and can take oral medications, they can certainly take Levaquin oral. Those kind of things you have to target there. And there are many other antimicrobials that can be targeted, IV to oral switch. Then expected duration of therapy. Sometimes we have a diagnosis and we are pretty sure this pneumonia we are going to treat for 5 days. And we emphasize people to put the duration when they're ordering an antibiotic. If they're going to give Levaquin for 5 days, put in there that you're going to give for 5 days. But sometimes we are not sure about it. In our antibiotic ordering system, we have introduced place where they have to put a diagnosis. If not, you can't order it. Perhaps something, making it mandatory to put a duration can come into picture, but there are both pros and cons to it. Often in bigger hospitals, different hospitals cover the patient different days. In my own service, if somebody has a clinic, then we tend to cover their patients. And at that time, we might miss the stops that other physicians have put. We have to reassess again, not just 48, 72 hours. If things are not changed or we don't have culture-directed therapy, we can always revisit that chart on the 5th day. And also people going on outpatient IV antibiotics, we have to make sure that those are appropriate. I have seen people get IV Levaquin as outpatient, which we never do it. It can safely be switched to oral. We don't need IV Levaquin outpatient. So those are the things where we intervene. Haven't seen that for a long time, but I do see that off and on in outpatient consults. So some of the advantages of having antibiotic timeout is self-stewardship, because there is not always an infectious disease physician or infectious disease pharmacist available as policing your patient care. So many places, if you don't have those facilities, or even if you do, you are your own antibiotic steward. You are your patient's advocate. You have to do best for the patient and what's safe for the patient. So try to take it upon yourself to make these changes and talk with each other, in your physician's lounge or wherever you interact with other people. There has to be a behavioral change in physician practice for this to happen, and it does take time. The good part is that we are not having a timeout, in a day. I mean, we have 2 to 3 days for them to get the culture data, get all the diagnostic tests, CT scans, MRIs, so that we can make an informed decision. Once we have the resources, or we have an EMR that will help us in our self-stewardship, then you don't need much of resources, manual resources like a lot of pharmacists for that. But initially, I think we do need some resources and some help from IT department to implement these things in our EMR. Prospective audit and feedback is very important. It again depends on the facility. Most of the smaller facilities, the internists that are at the same level. I always say somebody should step up and become a physician champion so that you can converse with your colleagues regarding inappropriate antimicrobial use or, many other things that we do on stewardship in an appropriate way, because most of the time, some physicians don't like to hear that from pharmacists, so you have to step up. Again, some disadvantages are, okay, you're addressing this at 48 hours, 72 hours. What if we have an alternate diagnosis right on the first day? I mean, you might get an influenza swab after you put in the orders 7 hours later, you know, or you get a chest x-ray and you look at it, you know, the next day early in the morning. I mean, that is the time you have to just stop the antibiotics if you have alternative diagnosis. We are not waiting for 48 or 72 hours. So reassessment time may result in unnecessary exposure to antimicrobials in those cases. Next slide, please. As any other process that we implement, we face barriers everywhere. There are hurdles. We face barriers more so at provider level than pharmacy level. Providers and stewardship team sometimes are just overwhelmed with the number of patients and the scope of interventions if you don't have adequate staff. Providers often resist the proposed interventions and just because they're not comfortable in de-escalating antibiotics, and sometimes they don't like pharmacists calling them. We, in our facility now, all providers have been educated that they will receive phone calls from pharmacists. Every meeting that we attend, we kind of emphasize that so they become comfortable conversing with the pharmacist. And they are there to help us, and that's what they have to realize. Some providers are just don't keep up with the new treatment guidelines. So at that time, you have to intervene and tell them that this is what is recommended now, and these are from the new guidelines. So provider education comes here. Alert fatigue does happen to us when there are too many alerts, too many pop-ups coming. When you open a chart, it is very annoying. I mean, we have some sepsis alerts like that, and even though we might not address that problem, we have to go through some clicks to get rid of it. So that is one of the things that we don't like. So some solutions, I really have to tell you, I mean, I'm not here to tell you what to do because the facility I work and the facility you work might be two different things. You have to figure out your own unmet stewardship needs based on your facility size, your available resources, and what do you want to target first. Prioritize the intervention. You know, is antibiotic timeout something that you want to focus on right in the beginning? You want to focus on maybe one antibiotic, maybe two to start with, or you have some other needs that need to be addressed first. Look for areas with clear evidence so that you can support your decisions and go through the available resources and experiences what other people are doing. Engage bedside nurses in interventions. It's very important to engage nurses, especially when I'm, you know, going and seeing a patient. A nurse would approach me and say, "Are you continuing this vancomycin?" I mean, that is a good enough reminder for us to think, do we need to? But again, it all boils down to the comfort level of nurses interacting with physicians and their workload too. The one thing that catches a provider's eye is compliance data. So if we introduce a process and we monitor compliance, we need to let them know what their compliance is. It can be posted on dashboards, anywhere. Obviously, you have to be anonymous, not using anybody's name. Just yesterday, I gave a lecture to in surgery grand rounds about C. diff. My whole goal was to tell them how many, you know, patients on medical service had C. diff and how many on surgical surgery service had C. diff, and their proportion was higher when compared to medical floor, depending upon the number of patients admitted and discharged. So it's good for them to know that they are at the not so good data, and they look into it and be careful about it. And other times, you know, really a physician leader has to intervene and get the provider who's not being compliant, you know, in a room and really provide face-to-face feedback and possibly even address if they are uncomfortable doing something. You might, you know, provide support. Next slide, please. So some solutions here, most of them I spoke about already. Stewardship team, engaging other providers is very important. Sometimes it's good to just discuss these things in your group, asking what do you think needs to be done next, or what intervention should be we stewardship team should be taking next. Once you involve other people, they are more inclined to support you. Peer benchmarking, now this is becoming more and more popular. You can, submit the data compared to other hospitals in your state, or, it can be national data too to the CDC, and see where you stand. You're not going to be fined for these things, but it's good for you to know where you should focus your stewardship needs. Implements clinical decision tools in EMR. Again, it depends on how good an EMR you have, how best tools you have in the EMR. Definitely an education of the product that you have is very important. They might be places where you can introduce things that will help you, narrow down the patient's list to patients being on more than 3 days of antibiotics or something like that. Something that helps you pick out those charts. You can also introduce some guidelines, order sets, and best practice alerts in that. We do have order sets that we review every couple years. You can also have links to guidelines that providers can go and check, make sure that they are treating things right. IT support is very important in today's world, and again, not everybody's fortunate about that, but definitely, we struggle with IT ourselves. More and more things are being centralized, and it is like all the hospitals within the system should agree to it. So that takes a lot of time, and then you lose focus on those things. Next slide, please. So it's very important to have multidisciplinary team approach. Certainly a physician champion should be there, a pharmacist champion. These are the two key leaders in your stewardship meetings. You can have nursing managers or infection preventionists, microbiologists. There we can talk about some cultures and reporting. IT support, again, most important. Ultimately, it's hospital administration who you have to report. So they are a part of team too. Next slide, please. This is just a good diagram here that shows different people involved and need to be involved. Patient care providers also are very important, especially when you are talking about, transferring patient, or you're talking about outpatient IV antibiotic therapy. Quality nurses are also there in some of the meetings. Next slide, please. So timeout process in hospitals. I am repeating some of the things again and again just to emphasize those. You might see me talking the same thing in each slide, but again, it's clinical pharmacist with appropriate training is very important. Technical advances and automation is very important, especially for notification and alerts. And depending upon the EMR you have, you can tailor things to automatic stop dates or something that can alert on a bug-drug mismatch. Several studies also reported a decrease in antimicrobial use, decreased antimicrobial resistance, and reduction in hospital-acquired C. diff. That is an important issue in hospitals now. Next slide, please. So these are some of the metrics, and I think everybody can come up with their own metrics, what they can measure. Compliance is something that is very important. Compliance and feedback is important. As a provider, I can tell you that people will only want to know how well they are doing, and you can get that data out to them. Prospective audit with intervention and feedback. Definitely, we can have a metrics around antimicrobial use, days of therapy, and show the decrease in antimicrobial use. And if we have a measurable clinical outcome that we can measure, such as hospital-acquired infection rates, C. diff rates, length of stay, if antibiotics are de-escalated earlier or switched to oral therapy earlier, then this certainly can shorten the length of stay. Next slide, please. So remember the word I talked about, self-stewardship. Here's an article from McGill University where researchers examined the effectiveness of antibiotic timeout. So providers used a structured timeout by an electronic checklist, and the study involved 679 patients over a period of 18 months on an internal medicine service, and they were their own stewards. These were residents, these were internists, and what they saw was at the end of the study period, this antibiotic self-stewardship bundle that was introduced reduced antibiotic use, which was measured as defined daily doses for 1,000 days. And they showed reduction in cost because there was less use of antibiotics. They also, even though this was not their goal, they noted a small decline in C. diff infections in their facility. Next slide, please. Here's another study published in 2015. It was a pilot test that was conducted at a tertiary teaching hospital. They focused on two antibiotics, vancomycin and zosyn, which is everybody's favorite when a patient comes in. That's what they get started on. But they did have a policy where if they want to continue beyond 3 days, they require infectious disease approval. So what they did was they introduced this timeout program that included 3 components: an electronic dashboard with aggregated infection-relevant data such as labs, imaging, white blood cell count, maybe a CRP, things like that. And then they created a templated note in EMR. So you review this infection-relevant data, then there is a note in EMR that provided review of antibiotics. So these are the antibiotics patient is on, and then an approval to continue or stop or change. This was an educational and a social campaign. People were educated regarding this. Next slide, please. And the results were compared to the prior year. They did report decrease in usage of antibiotics. More so, they also noted a physician satisfaction. This is hard to achieve, though. I will tell you that physicians becoming, more aware of the new process that was implemented. But this also gave them more self-confidence that they have a support of this data that's out there, and EMR template is easy to use, and it boosted their confidence level, and they became more comfortable. These physicians did not seek any approval from ID team or stewardship team as they started using it. And it was noted that there was increased rate of discontinuation of vancomycin and zosyn. Next slide, please. This is an abstract that was recently presented in Infectious Disease Week in 2018 in October. Here they utilized the electronic medical record. So they retrospectively evaluated the impact of electronic antibiotic timeout alert within the EPIC electronic health record on provider prescribing patterns. And the primary outcome was de-escalation or discontinuation of antibiotics within 12 hours of the alert. Next slide, please. So this was introduced for 4 months. Data analysis included 122 patients. A median of 3 alerts were triggered per patient. De-escalation opportunity was noted in 34.7% of alerts, and de-escalation events occurred in 34.3%, so that was pretty good. Zosyn was the most frequently de-escalated antibiotics. Again, the broader spectrum antibiotic de-escalation is our goal. So in conclusion, impact of electronic antibiotic timeout. An electronic antibiotic timeout alert triggered only on the basis of drug and duration. It did not take into picture the culture data or anything as such. So it was still up to the provider to look that up. Hence, it lacked specificity in identifying opportunities for antibiotic de-escalation. So sometimes if people don't read their data and don't have it available right away, they usually try to ignore the alert. De-escalation occurs significantly more frequently with infectious disease team involvement. Next slide, please. So here I talk a few slides of our experience in Mercy. These slides were provided by Jeff Brock, my infectious disease pharmacist. He's been there for decades, so he has a good idea of what was implemented and how the process worked for a while, and then this had to stop. We actually had auto stop, 7-day auto stop for most antimicrobials. There were some exclusions like antiretroviral agents and Tamiflu and those kind of things. At that time, when we had a hard chart that every provider went and wrote their note in, green stickers were placed in the order section of the medical record, which prompted providers to review the need to continue antibiotics. And if continuation order wasn't written, antimicrobials were discontinued. So there was a very short period of time when that needed to be signed and a box needed to be checked to continue or discontinue. But if that was not completed, then because it's an auto stop, antimicrobials were discontinued. Next slide, please. As I said, the system worked for a number of years to identify patients on day 7 of antibiotics. But as you know, we want to move to more electronic systems. Providers had new electronic systems. Pharmacy software was upgraded, and this was the time when everything, came to a halt. Basically, there was breakdown in system, and antibiotics were stopped without notifications, and that put some of the cases of, like bacteremias or endocarditis or things that needed longer antibiotic courses without notification. Antibiotic was stopped, and providers were unaware of it until somebody picked up on day 3 that the patient is not on any antibiotics. Next slide, please. So there is literature on risk and benefits of auto stops. However, there's not much of evidence that they reduce duration of therapy. Risk of inadvertent stoppage was a real thing, and that affects patient care. So you have to be careful in this auto stop things. Decision was made to discontinue this process, and now it is more and more on stewardship team to go through the charts and get help from the software they have to pick the charts that patients are on longer durations of antibiotic. Next slide, please. So we did have upgraded Cerner EMR that providers and pharmacists and everyone uses. Reevaluated the possibility of reintroducing these automatic stop orders. As I said, it is becoming more and more difficult when things are centralized and you have providers who don't like notifications or pop-up windows. Ultimately, we made a decision to stop this auto stop thing, and because of the limitations of EMR system, but we will at some point figure out how best to notify providers and introduce antibiotic timeout, hopefully soon. We also have to figure out who these pop-ups and alerts should go to. That's the most important thing. Every provider doesn't have to go through the alert system if they are not dealing with antimicrobial. So at this point, basically, stewardship team is responsible for antibiotic timeout and reviewing this patient chart and communicating with the provider to de-escalate or stop antibiotics. Pharmacy EMR software is Theradoc that they use, and I think these things get upgraded frequently, and you will have more and more new things ingrained in there that you can utilize. Other thing is we have to train more pharmacists to help with chart reviews. Next slide, please. There are some advantages and there are some disadvantages to this practice. Again, most of the diagnoses now usually point out to 5 days or 7 days of duration. Perhaps you can have your automatic stop orders at that 5 days or 7 days. There are a few diagnoses that need longer therapy, and those are the things that you don't want to miss. It does certainly reduces drug costs and encourages reassessment of need. It may be useful in situations where there is lack of clinical pharmacy services, because if your EMR is programmed in a way that you yourself can be your own stewards and address things right away, then you don't really need pharmacy force to review those charts. Certainly, the less the duration of antibiotic decreases adverse effects of drug and adverse effects such as C. diff. Next slide, please. But there are certainly disadvantages to it. Premature stopping of antibiotic due to misnotification is the biggest thing that affects patient care, and especially there is a lag of like 2-3 days before somebody realizes that this patient with endocarditis is not on daptomycin. There is certainly risk of long durations of therapy if provider just reorders and continues the antibiotic because they're not familiar with the patient. So more and more problems come if there is no continuity of care and you're not aware of the patient. It is somewhat labor intensive if electronic notifications are not built in. And there is no evidence that automatic stop policies improve rational use or decrease resistance. So we will talk a little bit about core element number 4, action again here. There is a document, Antibiotic Stewardship Playbook, that is out there. Everybody can access it. Most of this was obtained from there, and I have it in resources section also. So basically, this says that we have to implement some process to improve antibiotic use, and interventions should be measurable. With the outcomes should be measurable, and stewardship team should monitor this and should report it to hospital administration. Interventions should take into account the size of the hospital, the local needs of the hospital, the pharmacy staff, nursing staff, and physician comfort level for championing this cause. So this breaks down to basic implementation things, intermediate and advanced. Basic ones are a more system-wide approach. Intermediate are more patient-specific interventions, and advanced are diagnosis and infection-specific interventions. Next slide, please. So system-wide interventions such as policy to review antibiotic orders can be implemented, documentation of diagnosis, why that antibiotic is being used and the expected duration, treatment recommendations based on guidelines and local susceptibilities, possibly have a place where provider can easily access your local antibiogram, and also has a link that connects them to latest guidelines. That is certainly very helpful for providers. Standardized order forms on paper or built-in EMR are also very helpful. Patient-specific interventions are like antibiotic timeout we talked about. A stewardship team can take lead in this, but primary teams can do their own self-stewardship, and we can monitor that. IV to oral switch we talked about. Pharmacy guidance for appropriate dosage is very important. And as providers, we are just so busy that we don't look into, BMI of the patient, or was the creatinine clearance, and we do have all kinds of tools on our phones to calculate dose of antibiotics, but we really don't have time. That's when pharmacies steps up and say, we have to increase the dose because patient is obese and BMI is this, or the creatinine is worsening, we have to decrease the dose. And again, I am fortunate that sometimes pharmacy folks round with me, and I know my patients are cared for, and we try to do the best thing for them. And we also have good support of our ID pharmacists. Optimizing dosing is very important for organisms. And then again, not everybody looks at the MIC of an organism, and if it's a higher MIC, do providers change therapy based on that? It again is time consuming, and not many people are familiar with numbers also of MIC and intermediate susceptibility. Automatic alerts to avoid duplicate therapy are very helpful, and time-sensitive automatic stop orders certainly can help in situations like surgical prophylaxis, and we have to have caution in certain places there. Diagnosis and infection-specific interventions include rapid pathogen identification by rapid diagnostics. So here comes the microbiologist, and you can talk with them and see what's best for your hospital, and what method of rapid diagnostic test you can introduce. Use of biomarkers, we have one procalcitonin that can be used for distinguishing viral versus bacterial pneumonia, or sepsis versus no sepsis, but people really have to have knowledge of this procalcitonin test. I will tell you, a lot of times this is used, people don't know about it, and it's an automatic order to put procalcitonin. In patients with end-stage renal disease, it can be elevated. Even in people with sepsis, the first procalcitonin might be normal or just a bit elevated, but the next day if you check, it will be 20. So you need to have knowledge of the test that you order. Timely and appropriate culture is very important, preferring culture before antimicrobial is given. And protocols based on evidence-based medicine to improve antimicrobial use can be implemented and built in your EMR, such as sepsis, pneumonia protocols, UTI, SSI, surgical site infections, and bacteremias. Here are a few ideas. Small critical care critical access hospitals and other hospitals based on your size. They might be just a few patients on antibiotics at a time. And at this time, and even if you have one or two pharmacists, they can certainly review all those charts appropriately on time. But larger facilities face a lot of problems because there are numerous patients on antibiotics each day, hundreds of them, and if you don't have pharmacy staff, it is difficult to go through each and every chart every day. So pop-up reminders again come into play, but again, it also depends on providers would just ignore them or they would address them. And we should remind ourselves and evaluate the ongoing need for antibiotics. If no options for alerts, you can generate reports to identify patients on antimicrobials in your EMR. Again, as I said, pharmacy may not be able to perform all the timeouts. IT support and user-friendly EMR is needed, and EMR can assist us in several ways. Culture reporting, culture data, and address the clinical decision support system built in your software. Few slides here are about resources. I did send a Word document regarding these. Next slide, please. Next slide, please. And I will tell you there are numerous resources here, and I do have to admit I did not have time to review all those resources. So there may be some websites that are not working. I apologize for that. I did not go through every resource that I showed you there. I definitely went through all the references I put in there. If anybody has any questions, you can email me, and we can address it if you don't think about those questions at this time. Thank you.
Dr. Froese, this is Kate at IHC, and I want to thank you for that detailed presentation on antibiotic timeout. Antibiotic stewardship is something we continue to focus on in our HIIN work, and I know that that's an intervention that a lot of hospitals are using currently, so we appreciate you sharing your knowledge with us today. At this time, we're going to transition to our next session. I know that there's a short break built into today's agenda, but we're running just a bit behind schedule. And so we're going to go ahead and keep moving with our next session. It's titled Behavioral Health Strategies for Hospitalized Patients. It's my pleasure to introduce Steve Johnson, who's speaking on this session. Steve serves as the Behavioral Health Administrator for Broadlands Medical Center here in Des Moines. He's earned his bachelor's degree from Drake and his master's degree in social work from St. Louis University. He started his career at Broadlands Medical Center as an outreach coordinator and moved to Magellan Health Services as a clinical director. He assisted United Healthcare as their executive director for behavioral health before returning back to Broadlands in 2016. Steve, thanks so much for joining us. Steve, the floor is yours. When you're ready, just go ahead and unmute your phone line.
Just 1 minute, we'll get started.
As Steve prepares for his presentation, we're just moving him into our webinar space. I just want to remind you all that today's presentation, slide decks, and resources will be sent out in a follow-up email following today's session along with your program evaluation. So I'll ask that you take some time to fill out that evaluation, and then you'll be able to print your certificate of attendance for today. Steve, when you're ready, go ahead. Thank you.
I am on. Thank you. Hi, everybody. I'm Steve Johnson, and I'm with Broadlands Medical Center here in Des Moines. So, sitting in the beautiful Iowa Health Collaborative offices. So, I've got Robin Van Camp with us, one of our very experienced nurses at the in our inpatient mental health. So, we're both excited to be here today and to try to share a little bit of information and have certainly want to make sure you have some time for questions at the end. So just by means of background, because I'm sure we've got some folks from around the state, I just wanted to give you just a little bit of background on Broadlands so you kind of know if we're talking or if we're emphasizing some certain points, just that you know that you know, sort of where we come from. So as Broadlands developed its psychiatric services, especially around way back when, in like the 1970s and early 1980s. So Sidney Sands was a notable psychiatrist back in those days. And then as we built one of our first larger psychiatric units, the Polk County leaders at that time, their policy initiative was really to not have to use any of the, at that time, state hospitals, but to keep keep patients in the local area at Broadlands and locally. And I think as we've evolved through the years now, we serve all adults at the inpatient level. We've got a 30-bed ground level unit, then we've got a 14-bed lower level unit we just added last year. And so I would say we do not transfer anyone that comes in. In the last 2 years, we've transferred one patient from to one of the state hospitals, and that was just due to, it was primarily a very forensic and criminal issue. So, but other than that, we keep everybody at Broadlawns and treat them there. So we probably have, I'd say, higher rates, at least as you look here, maybe compared to the average, higher rates of schizophrenia and bipolar disorder. Pretty high, on the symptom scale. We also have the majority of our admissions are related to either a Chapter 229 or 125 court order. So we do have, we do deal with courts a lot, and so so I just want to give you a little bit of background, so you kind of knew a little bit about our patient population and what may cause us to emphasize certain points, from a strategy standpoint. So let's see, and I just, of course, okay, good. Well, remember to move that mouse around because we're at a guest location here. So I think we'll just jump right into it here. And so I think we're on the title. We can go to the, yeah, thank you. So the engagement period, we view as very, very important, and really starts, for us, starts in the emergency room. And, we'll, as we're getting a call from law enforcement, as we're getting, maybe a call from family or others about a potential admission out of our emergency room, we also do have a 24/7 crisis line. So embedded within our emergency room, we do have mental health staff 24/7. It's either going to be it'll be some type of a licensed mental health person, either master's level or nursing. And so they're doing all the assessments for mental health within the emergency room 24/7. So and so as someone does come in the emergency room, then we definitely do want to start in the emergency room. And so, for example, I might hear about somebody that has been there before, the emergency room staff are, saying, okay, well, we've seen this person before. This are some of the issues with this person. So, I think the risk here is that you can tend to sort of depersonalize, if you will, some of your thoughts and beliefs before the patient even gets there. So what we really try to do is make sure that as that individual comes in, it doesn't matter if they're coming in as a court order and they're in handcuffs, or they're walking in voluntarily with family members. There's some differences in those two presentations, obviously just related to security, but it really doesn't matter from a person standpoint. We really want to then, make good eye contact, all the things we say there in terms of really, as any of us would want to be treated, or as we would want, any of our family members treated. So, and then, the belief, I think, there is that contact does set the tone, just like any of our relationships, really, that initial contact then does affect how things go. And so we on any type of a mental health type situation, we're going to have an individual is likely going to be in our emergency room somewhere in the 3 to 4 hour period while we try to figure out, are we going to, do they need to go inpatient? Do we have inpatient beds at our location, or are we going to need to, if they do need inpatient, are we going to look at transferring them out to another hospital and attempting that, or can they, go back to the community or another resource? So within the emergency room, we've tried to design a number of our options that we look at in terms of choices. So that that's just going to start with some basic things as they come in, like, and I'll try to it's a little bit bifurcated here, because we may put let's say a patient comes in voluntary presenting with family and they go into a regular emergency room, or let's say we get someone who's on a 229 quarter and we've got a locked area that's got 4 rooms in it where we put those folks that are in. So as people come in that locked hallway area of the ED, then we're going to start off with, okay, have you had anything to eat lately? Have you had anything to drink lately? Would you like a blanket? And as I'm sure many of you have seen, as they come into under quarter, they may be surprised and that they may have just been picked up and weren't expected to be picked up. They may be mad at the people that may have filed commitments on. They may be very symptomatic, all those things. So I think our goal is to try to support them as much as possible, greet them, make sure they, know what some of their options are. But from a basic standpoint, they do need a blanket. We can get people showers right there in the emergency room too, so we have access to that. We've got some items we can give them, for snacks until the next meal. And so our hospital has, as I'm sure many of you do too, is we've got luckily a cafeteria we can access for the patient meals. And so we can also give them a choice on that in terms of what they want to. And because we do know that, mealtime and food is very important. Had one situation that's just coming to my memory here where we had a gentleman who, a very large gentleman that had some autistic behaviors that was getting very angry, and it appeared, at least from the information we got in, that he really had a very limited menu in his life. So it was like chicken nuggets. So I made a quick call down to our cafeteria and said, I need some chicken nuggets ASAP. So there's times in which you may be into situations where you kind of know what may be things that can assist you on this, but this is really all part of the patient engagement experience. The more we can be engaged with somebody, the more we can, because we're not going to start off talking about, for example, what abuse occurred in their family. We're going to start off with how to connect with them, how to make sure, they're getting some, their basic needs being met, and how, then roll into the assessment, and how we can help them. So I think next slide, please. And then here, one thing is, don't assume, that we, really know what the patient needs. I think I can, just in terms of us clinical staff, sometimes we, we've seen some of these folks before, or we've read some information. People may say, well, they just need to take their medications. If they took their medications, well, everything would be fine. And, that may be true some of the time, but usually there's more complexities to them that we all know. But so we really want to, if they do have history available, we want to try to read that and, get up to speed on that. But I think our main message here is really to look at, what brought them in today. Many of the issues that our patients are dealing with are longstanding, and whether it's hearing voices that, are better on medication, but still they may be experiencing voices despite, strong medication. And they may be non-compliant or variable in their compliance, because we know many of these medications also have some baggage, weight gain, sexual side effects, other things. So we know that's in play there too. But really, from a patient, sort of why are they here? And some people may say, well, I was court-ordered by my family, so it really wasn't my idea. So, so I think what we try to do in our engagement and assessment phase is, really try to, help them look at those factors. And if I got court-ordered by my family, I don't like this. Well, okay, so what led to all that, and how can we, work on, some of those presenting issues and try to figure out how to not get yourself, in this position again. And many of them are angry that they're in this position, and they need some time to process that anger and so forth. And that can be a long or a little bit with a lot of people. It depends on the experience. But so the next couple of bullet points just kind of go further into that in terms of, what brought them in today. There may be an increase in symptoms, of course, but it also could be some of their coping. And I know one example that was brought up to me earlier in my career is a gentleman who presents to the emergency room hearing voices and fight with his mom. And so, you know, he gets an assessment, he gets admitted to the hospital, and he, you know, gets a lot of treatment for those voices. But in reality, at least in his case, was really the primary issue was his mom's his payee. They had a fight about money, and his baseline is he hears voices. So really the presenting issue and then the treating issue is really about his relationship with his mom, the fact that his mom is his guardian, and how can that be, you know, resolved. So, you know, we know not all of our issues are primarily symptom or medication based. Many times they are, don't get me wrong, but I think also we need to look at what are also those psychosocial relationship issues that everybody has. We all have those in our families and social life and everything, right? So the people with a mental illness are no different in that they, as we look at helping them resolve those conflicts, it's important to really tease out, you know. So some people may call it the why now. Some people may call it presenting complaint. It really doesn't matter what you call it, but we really do believe that there is a connection there between what was the reason they came in and then the treatment plan we end up formulating throughout the rest of the stay. And I've got another slide at the end that we'll go into that, you know, a little bit more. And usually you're looking at, as it says in that fourth bullet point there, you're kind of looking at the last 48 hours. You know, you have a number of folks come in and says, well, I've been suicidal for 10 years. Okay, or, you know, I've been, you know, depressed but, you know, so those are sort of comments just to sort of, you know, them emphasizing how bad they feel, and we get that. And certainly that's challenging. Many times they have been suffering, you know, for that length of time, but we're trying to really walk back through with them what's really happened over the last 24 to 48 hours that really, you know, led you to come in here, and just sort of walking that back with them. And what are the things that, you know, did they try to call someone and then that fell through, or did they, you know, they missed a appointment with their physician, or they, you know, had a fight with their girlfriend, and you know, that didn't go too well. Anyway, it's a little bit, you know, to me the assessment, and especially in this kind of stage, you're doing a little bit of detective work, because, you know, we're trying to, you know, we've taught people over the years to go to emergency rooms when they are not feeling safe, and so people do that. But at the same time, you know, we're trying to help them figure out what's not going right in their life. That's not, it may feel to them like it's just this big blob. I've got 18 things that are going wrong, and I feel like I want to commit suicide. But what really, between their symptoms, their behaviors, and their coping, really they perceive failed them in the last 24 to 48 hours that led them to come in. So next slide, please. Great, got some nice pay. So that's part of our inpatient unit there. We've got some beautiful units at Broadlawns that you know, really excited about. And we've got and you know, it's Iowa when you come on the psychiatric unit, and that particular you know, mural on the wall there. But so we bring people down this particular side. We're talking about as we admit someone, we've got a bed for them. We've got staff that come down from the inpatient level to pick them up. We transport them, you know, in a wheelchair. So this is sort of their welcome to the unit. So again, we're looking at, and you know, we've got patients that are not talking, not smiling, all those things. But I think as much as we as staff then can model the behavior that we want, and be as engaging as possible, because they may not always be engaging because they're in tough circumstances. So, you know, same things there in terms of the basic, you know, eye contact, and then you know, try to give them some next steps. Some may have been admitted before, some may have not. So what are some of those things they can expect? And that's going to depend on the time of day they're admitted. Most of the people we're admitting are into the mid to late afternoon and you know, early evening. So you know, we're gonna you know, what are they gonna do when they check in? What are the visiting hours? Next meal times, and if we've missed a meal time, we'll do our best to get them like a cold plate or something. So you know, what are we looking at in terms of, you know, medication schedule? So all those basic things that that may be rolling through the patient's mind, but many times because of the things they're going through, they may not feel comfortable. And always bring that up, just like when any of us go to a medical visit or something, or in, we always think of our best questions later when we, you know, yeah, try to find out when they last ate. Do they need to make a phone call? Some people, you know, they may have been important people in their life that don't know what's going on, and some may, you know, they want to notify, some they don't. But we have access to patient phone calls both in the emergency room and on the inpatient unit.
And we do 2 orientations. We do one when the patient is brought down to the unit, and a second one either later that day or the next morning with our program specialist that explains more of what's going on in the groups and that are offered on the unit.
And just so they get, you know, some idea of what they're looking at. Next slide, please. Yeah, again, more, you know, sort of more of the same here in terms of you know, are we looking at 15-minute checks? Are they on, some of our rooms are video monitored just due to the, you know, safety needs. As Robin talked about, the activity schedule, and so we've got a full activity schedule on the list of which staff are on. You know, when we know about it, who's gonna be their provider, you know, who's going to be their nurse for the rest of that shift, all those things. And some, you know, some people, not everybody thinks this is important, but we'll have some patients I know that will care about, yeah, well, what if there's a fire? What are other safe locations? And that can be something we've got those, I'm sure as many of you do, we've got those maps out and so forth. So, but show them to their room. Some of our rooms have roommates, the particular room. So this is one of our actual rooms on our 30-bed unit that you're looking at there. So some rooms have roommates, some don't. So a nice window there, you know, bathroom. And so we want to, sometimes the roommate's important. So we want to introduce them to the roommate if that's, you know, available at that time. And then we're lucky there. We've got a lot of good open space in the center of as you first come in. Then the rooms are off into various wings. So if there's some uncomfortableness with your roommate, there's a lot of other places to go to sort of, you know.
And we will try to move people around as needed with roommate issues.
That's great. Yeah, most of us have sometimes from our younger days, but some of us have roommate, you know, stories. So we want to, you know, that's a great point, Robin, because we do try to make adjustments for people, you know, when at all possible. And if patients have questions, you know, sometimes it'll be, I know the ones I hear are like medical concerns, and we do have, of course, we've got, you know, nurses available 24/7, but then we've also got mid-levels that oversee some of the more routine medical issues. And of course, being in a full-service hospital, we've also got consultation service available on various, you know, medical issues too. So, but if a patient does have a question, and we don't have the answer right away, we'll do our best to get that for them. So, all right, next slide, please. All right, then again, patient engagement, I know we're kind of going on, but we do feel like there's just really a lot of factors to this because, you know, I know Robin will concur this, the more we keep working at this, even if we don't see anything, you know, coming back from the patient, even in the first few days, maybe eventually, you know, you're sort of getting them to where, you know, they are, you know, getting a connection with maybe one of the staff or, you know, somebody, and you feel like you can so the engagement, the purpose of the engagement really is that first step, really, and then trying to move treatment along, in my mind. So we're really, and if we can have everybody, all the, because obviously, just I'm sure like a lot of your units, we've got a lot of different staff coming through, but the main piece is if we stick to these things, then we're going to have a much better chance of being successful in treatment. So involve family members. So we have a social work team that is going to get that family engagement also going when appropriate. We've got of course, visiting hours. We've got family, can visit on the unit with patient's permission. We've got family meeting rooms as well too. And we have, friends coming in as well too. So, we want to make sure that the patient has support around them if that's what they, if that's what they wish. And service providers as well. So we've got a number of mostly, if they're coming in from a group home or other type of placement where there's significant services, then we want to be able to be open to that too. And a lot of that's going to be collateral phone contact, but it's also going to be looking at a situation where is this a placement they can go back to, because sometimes that'll certainly come up as we're looking at patients that are coming in for inpatient psychiatric services. Sometimes there may be a disruption in that placement, so we need to work with that provider to figure out the next steps. And is this something? Of course, we're always pushing for can this placement be retained? Because I would have to say some of our more high need patients that you really do see a pattern of going from placement to placement to placement, which I think all of us would agree that's changing your housing every 6 months has an effect on your mental health in and of itself. So as a team, we're always pushing for more permanency in housing, but the reality is that does have to change sometimes. So we have to work on, being able, and then as we're looking at trying to, engage that patient and their family and potentially a new service provider, what are the kind of things that we can help you with on the unit that are going to get you ready for that interview with that new placement? What are the kind of things we can, that maybe were lessons learned in that previous placement that we can, let's make a list. Let's really, so we'll get a little bit more of that in the care planning too, which was Robin's second comment here on the slide in terms of, really engaging the patient in care planning. So we know that as patients, from a big picture perspective, they come in the emergency room, their belongings are taken from them. There's certainly a sense to sort of get in helpless mode, if you will. So then, but once we get them oriented to the unit, once we start the assessment, the treatment process, then the goal is to get out of that helpless mode and then really get in the mode of being able to, have us help you, have you help yourself, have us both, with all energy focused on, symptom improvement, all the things people are going to need to be able to be living and successful in the community. So next slide, please. All right, so this gets in. Now let me give a little bit of a background on this today. We did just within the past year shift to, so as we look at, again, this is another picture, this is one of our wings on the psychiatric unit. So we just did shift to a type of training called PROACT. And so PROACT is a up to 3-day training who does all 3 days of those training. Kind of depends on where you work. So if you're staff in the inpatient unit, you're going to have all 3 days. And so PROACT in and of itself is a much bigger topic than would really be a whole presentation in and of itself. But if you just Google PROACT out of California, you'll be able to see a little bit of the some of the philosophies behind it. We had prior to that, for a number of years we had management of aggressive persons. The nice thing for us, I'd say, about PROACT is there's been a significant reduction in many of our security calls, right?
Yeah.
So we've found within the past year of using PROACT that, so we have security alerts, we call them green codes, really where staff, we have buttons placed throughout the staff areas. We've also got staff carry panic buttons with them. So if there's any type of suspicion of any type of security alert, then we have all staff are on deck, so to speak. Security's notified, and so so those have dropped significantly since we started the PROACT. So we're very excited about that. And we just wanted to give you a little bit of a few snippets of some of the ideas behind PROACT and de-escalation, as it relates to our presentation here, and we thought might be, sort of helpful for you. And with the part of it is here, especially with crisis communication, the thing is that we do, similar to our example in the emergency room, is that we do want to have allow patients to feel and hopefully experience that there is some control in what they've got, because as we talked about, especially if someone's frustrated, they're upset, as their belongings are removed from them, as their many of their rights may have been taken away via court order, they've lost a lot of their control, right? So how much within the context of treatment in the unit, how can we offer back, a measure of that control so they can start to feel like, they're at least in control of some of this, activity. As we get into where maybe we do have a security alert and we're having to, use any type of medication for, calming, and that's Robin's comment here, which I think is a good one, is that the goal here with the medications is calming. And so it's not we're necessarily trying to put some people to sleep.
No,
right?
You just want to help them get through the situation.
And so, but one choice might be, may not apply with everybody, but should we ask the physician for some oral medications or injectables, right?
Yep. You want to get the orders from the physician, and you want to give the patient the choice. You want to try to get them to ask for the medication, but if a staff person may have to say, maybe you're really upset right now, maybe some medication would help, and try to get them to be agreeable, and then maybe agreeable to if they want an oral or if they want an injectable medication.
So give them some choice.
As many choices as possible.
There you go. Let's see, next slide, please. Okay, and I said I'm gonna go off my slide there. I'm gonna give a little bit more back into that. If you just go back to the previous slide just for a minute, sorry. I'm gonna talk thank you. So get just a little bit more into the details of the crisis communication, just because I think it could be, I'm sure these are things that you're doing many times with your own training, or sometimes, within your own, natural approach to things. But I wanted to highlight a few things from PROACT that I should have had a slide on this one, apologize, but I didn't, but it's kind of it's embedded in some of the ideas here. So the crisis communication, really the first goal, the main things are be patient and keep talking. So, and there's usually 4 sources of this patient type complaint where they may be starting to yell, they may be starting to, get visibly upset, they may be, just very distraught. And usually there's 4 sources here. One is fear, one is frustration, one is manipulation, and one is intimidation. So again, sorry I didn't have a slide on this, but we just wanted to, as we were talking about this, we just wanted to build out and give you a little bit more detail so you'd have something to sort of, take back with you and think about. But again, I'll say those: fear, frustration, manipulation, and intimidation. And then as we look at each one of those 4, and some of our strategies on that, so we know that fear is an emotional response, and there's usually a need in there, and so that may be sometimes irrational on the part of the patient, but there is a need there that they're trying to get met. But they may be fearful because I know we just had a patient this week she thought that she was delusional, and she thought that all the patients were nurses and that those nurses were trying to kill her. So obviously that's a We know that's a delusion, that's an irrational belief, but nonetheless, she had fear, you know, and we were having to do some court action with her, and so we were talking about it as a team. And some of the things you may see, you know, with this is you may see that they're prepared to sort of defend themselves. You may see that their facial expression is very, you know, like eyes wide open, like they really are fearful because they really, you know, in their mind, this is really their reality. You may see some gasping or even unable to speak. You may see some sort of shallow breathing on their part. So as staff then, in this type of a situation then, as staff then, one of our strategies then is to really look at a soft and low voice tone. We want to be as supportive as possible, and we want to be able to try to assure them that they're going to be okay. So we want to use phrases like, I want to help you feel safe. I'm not going to hurt you. And so, you know, which, unless we assess the situation properly, which can take some time sometimes, but if we have a pretty good assessment on this, that we believe that their actions are being driven out of fear, then our goal at that point is to help them feel safe, right? And it's going to be those kind of statements. It's going to be trying to, you know, assure them that whatever they're fearful of, we're not here to hurt them anyway. We're here to help them. And the other piece that comes in here that's a variable is you have different cultures. So different cultures may perceive this differently in terms of safety. So we've got a team of 5 full-time interpreters at Broadlawns, as well as access to both phone and video interpreters. So that can be needed here as well. And especially if there's a cultural issue and the family supportive and understanding, that may be something where you need to, you know, do that as well. Anything you'd add to the fear one or something?
No, not really. Safety first is a big thing, getting the patient to feel safe.
Yep, good. And that's really going to be based on that initial assessment. So that initial assessment, and if it wasn't caught there, you know, your nurse assigned to that patient is probably really going to have the best handle day to day. And of course, we'll have to include others as needed. But next one's frustration. So as patients, you're feeling frustrated. Oh, yeah, sorry, still on this slide. Sorry. So frustration is really an emotional response to being out of control. So, and we know this can certainly happen with people that are court ordered. You know, they feel like their rights have been taken away. They may not agree with the court order. On our unit, we take both mental health and substance use disorder court orders. So, you know, I mean, you may have had somebody that 24 hours ago was high on methamphetamine. They're much better now, and they have their faculties about them, and they're mad. You know, they're mad at the world because they've been courted. So on those out of control people, then they can again be tense. They can be you know, breathing very loud, breathing very heavy. They can be, you know, really tense and frustrated, muscles tense. And our strategy within that, and that gets into where it talks on here in this slide about lending control. So we're not giving up control, but we're really kind of lending control. And so this can be where you know, we're doing lots of listening, you know, to the patient. We may want to, and as we listen to them, again, just like Robin talked about before, there's lots of choices and so forth. We want to make sure our placement is we remain outside of their striking range. So if they would, you know, be in a position where they're going to be striking us, we want to be outside that range. But then we want to be able to be sort of directly in front of them and be able to have, you know, use our clear pronunciation, low tones, and, you know, would you like to sit or take a walk with me?
Make sure there's an escape route for both.
Yeah, good point. So Robin brought up, make sure you have an escape route so you're not backed into a corner, right?
And the patient can leave.
Yeah, and the patient can leave too. So we don't want to back ourselves into into a tight spot. So good point. And so really, and then we want to also look at some choices that we can take. You know, what are, you know, can we, you know, I really want to help you calm down. Could we, you know, go to your room and talk about this? Can we take a walk? Can we, you know, the next activity is going to be this. Can we, you know, go and give your significant other a call, and you know, to try to keep that, the overall umbrella here is crisis communication. You really want to keep talking as much as possible. And as you do, because the thing about, if you have a lot of talking, then you'd have a gap in silence, then you're really allowing an opportunity for action to take there that we really don't want. We don't want to give a window of opportunity open for action. So I'll move through these a little quicker just because I know our time is going to get short. Manipulation. We do know that, especially we have patients that have borderline personality disorder, emotional issues in their being able to control their emotions, and so really there, we try to, you know, obviously listen and so forth, but we really hear. We want to get that. Sometimes they like an audience. They like to be manipulative within an audience, and we want to be able to get them in a smaller situation and then try to talk through some of those things so we can help them manage their emotions. And sometimes just having a 0 to 10 scale on that too, just like I know we've used for you know, a number of years in other situations, but just trying to look at where they are with their emotions, and if they're at a 10, trying to say, well, how do you usually get down to a 5? Or, you know, many of these people have been dealing with this for some time. So unless they're asked a question on that, sometimes they don't think of, well, how really have I managed this before? Because many of them have, and sometimes some of the answers are within their own makeup. And lastly, intimidation. So we do know we have situations where staff feel intimidated. And you know, these are a situation exactly like Robin said. We need to make sure, if we're on the unit, we're talking to them, we make sure we've got an exit plan. But we you know, we want to be able to again offer some safe you know, choices to them. We want to you know, swearing, insulting, things that may be, you know, coming from them, we want to be able to bring that back down into, you know, what our next steps are. We want to, you know, engage them in treatment and what is the next thing that occurring, and to be able to transition them to that, because they may want one thing. We had one I know happened just this week, is a fight over somebody didn't get their cookie for dessert, and it turned into a major you know, uproar and so forth. And but being able to manage that situation at the time and get people, you know, focused into the next activity is, because really that's what we have to rely on. Is we've got our staff there, we've got our process, we've got our schedule, and to be able to, you know, engage them in the next thing that we'll be working on. Okay, now finally, next slide. Sorry. So we did want to touch on the final learning objective here, the care planning. So. And we just went through a Joint Commission review, as Robin knows, in July, and did, I would have to say that in certainly my history of Joint Commission reviews, this was certainly a lot on care planning. Our primary mental health reviewer was a social worker, and spent about 2 days on our inpatient unit just going over some of these items. Well, lost the screen. So similar to how we've been talking in the engagement, really looking at, now we have, just from a basic standpoint, let me just say our electronic medical record is Meditech. We do have a master treatment plan that is embedded within that medical record. And so we pull a lot of, you know, I'm sure just like your all's medical record, we have lots of pieces and lots of reports as people go through our systems. And I think that we're certainly by no means perfect on that master treatment plan, but I think that hopefully is the point where we can centralize some of this information. So again, back to what we talked about earlier in this presentation in terms of that presenting complaint. So trying to zero in on that And then, of course, all the information from the emergency room assessment. So we don't want to lose that. We've in our emergency room, we've got an emergency room physician that's made an assessment, and they've got usually about a 2-page assessment. We've also got, as I talked about in the emergency room, the social worker or nurse from a mental health perspective that's doing an assessment. So those assessments are already in our system. So as we go, they get admitted to the inpatient unit. We've got staff, our own multidisciplinary staff that are making assessments. We want to, capture that and then be able to. So we believe that, and we've all got different assessment tools or, similarities, but the outcome of that really should be the problems and strengths that are listed within the master treatment plan. And you can substitute master treatment plan for whatever you use, whatever you're using out there, service plan, treatment plan, whatever you use in your own system. But, and so these are, then as we meet with a patient and that assessment in the inpatient unit, really, we're trying to clarify with them what these problems and strengths are, and that which are the ones that, that need to be addressed, right? So, because our assessments can produce a number of problem areas and also some strength areas, of course. Everybody's, any one person is going to have strengths. So, and building up those strengths areas can mitigate problem areas. But really from a practical standpoint, what are the list of things that are going to go in the treatment plan that are really going to be worked on in their inpatient stay? So let's say, patient is delusional, patient has diabetes that, is uncontrolled at times. Let's just say we, stick with those two, right? And those are the two things that we're going to work on during the stay. I think, to me, and I think to us, that's more powerful than having 10 things, because they may have, as we know, many of our patients can have 10 different things. They may have a BMI in a certain category. They may have, delusional activity. They may have diabetes. They may have, they're behind on a lot of their preventative cares. They may have been abused at an earlier age, and there's some, unresolved issues there. But if we have 8 to 10 things that we're trying to improve on during that inpatient stay, really, how realistic is that? Really, we want a treatment plan that is really realistic for us and the patient to be able to, show progress during the inpatient stay. They're not going to be resolved. All things aren't going to be resolved, but they'll be improved to the point where once their risk improves, either whatever risk point brought them into the hospital, then that's the time for them to be discharged. And so Joint Commission brought up a few times, well, what are your discharge criteria? And we were like, okay, well, what are you talking about? Actual discharge criteria that are objective criteria, or are you talking about, because we would think more individualized. And after some discussions, it really hit home that this is really well tied in. So really, the discharge criteria is going back to the same problems and strengths that are listed, that have been listed in the master treatment plan. It's just that they've made improvements to the point where the provider feels like this is appropriate for discharge. So I said there, psychiatrist approves discharge when there's been significant progress together. So I'm hoping that you can see that there's a tie-in between all three of these things, and that if we do the master treatment plan correctly, we're not looking at 10 things on a master treatment plan. We're looking at maybe, think of any of us as we may have gone in the hospital and what areas need to be, and I'm sure if Robin started interviewing me, she could probably come up with 8 or 10 things that need to be changed about Steve Johnson. But for the focus of our work, this very intensive work that we're doing in a short amount of period in the inpatient level, that I would suggest, and you all may be very, very much better at this, but I would suggest that in most patients, we're going to have somewhere no more than 3 to 4 items that are either problems or strengths that we're going to work on during inpatient stay. And then we have sections in our electronic medical record that are discharge criteria, so we can specifically say, yes, their delusions are better, their diabetes is back under control, this is their self-control plan of the future, and we believe the discharge criteria have been met because we've improved the problems that were identified in the master treatment plan, and all three things hopefully flow together. So I think that is the end of our presentation here, and we would love to take time for some questions.
Steve, this is Kate Carpenter with the Iowa Healthcare Collaborative. I want to thank you both for your time and your presentation today. And in fact, it's just a beautiful segue, you know, some of your last comments into our next session. There has been a couple comments in through the chat box, and I would invite you to respond to those through the chat, if you would, as we move into our next session. I know Phyllis was asking, I think, Broadlands maybe is available to Polk County residents, so I'm wondering what's out there for behavioral health beds outside of Polk County and then the other counties around the state, if I understand your question correctly, Phyllis. And so we'd love to hear your thoughts through the chat box, Steve, on those things and the other comments that have been made. I want to thank you again for your presentation. We're going to move into the final session of the day, and I promise we are keeping an eye on the time. The last and final session is brief, but we'd like to introduce some newly developed resources regarding, hang on just a second, I'm just trying to get the slide deck up for you. There we go, thank you. Newly developed resources to reduce med-surg readmissions related to behavioral health and substance abuse. This new resource package was developed recently by the HIIN's Readmission Affinity Group. And really what that means is there's folks from all the 16 HIINs across the nation, of course, that are working on readmissions. Those leads have met and created work groups to help produce this product that can hopefully be used by hospitals around our country. The new resource, its intent is really to create a compendium of already existing resources that we could all use to enhance our awareness and education for best managing patients with behavioral health or substance abuse complexities on our own med surgical units. And this resource was sent out previous to the session today. It's available on Innovation, also through healthcare communities, and will be included in the post-learning community follow-up. So, you know, as you know, one of the major goals of the Partnership for Patients is to reduce readmissions by 12%. And so as we move through this brief session, some of the questions I'd like you to reflect on and think about is, do you consider patients with behavioral health conditions or substance abuse to be at risk for readmission? What resources do you currently have to help meet the needs of these patients? And what resources do you currently have for your med-surg units, for your teams and for your staff locally to effectively manage these patients? So a little background of why this is created, you know, we all just heard Steve kind of overview some of the approaches that they take at Broadlands as patients enter in through the emergency room and then are admitted to the unit. We know here locally in our state that there's a shortage still, unfortunately, of beds for folks with these complexities. And the reality is that oftentimes around our state and in rural areas, we're admitting patients to the med-surg unit for something that could be pneumonia or cancer or other things completely unrelated. But they have these comorbidities. They have behavioral health needs that don't necessarily have anything to do specifically perhaps with their admitting diagnosis, but really still impact their care and what our effective care planning should be and how we can help ensure that they have a successful transition of care. We know that hospital access to professional and support services for behavioral health referrals and specialists are varied and often limiting. So, you know, statistic-wise, we know that 68% of behavioral health patients have a medical comorbidity, and also on the flip side that 30% of adults with a non-mental health medical condition, for example, chronic illnesses also have a mental health condition. So there's two sides of the coin. Hundreds of thousands of people nationally are in need of mental health care and seek help from local hospitals. 37% of these individuals with disabilities or on Medicare have a serious mental disorder, and you can see the reference cited there. So it's, with all these things in mind that this group really assembled to try and put together a package that put all the resources that we currently have in one place so it would be easier for hospitals to find and use them. As we started brainstorming, some of the main drivers, we dumped our thoughts into 4 buckets. The first is optimized discharge processes. The second is policy and protocols. Thirdly, staff education. And importantly, the last one is partnerships. These are the things that we really found were primary drivers to reducing med-surg readmissions related to behavioral health. So I want to talk to you really briefly about each of these 4 buckets and some of the secondary drivers that have been built in. You'll see if you look up the resource package that there's been resources developed, I shouldn't say newly developed, but collected for each of these secondary drivers. The resources contained within the package contain everything from training videos to journal articles to tools and resources. So as we're going through these drivers, I would really encourage you to take a peek at this resource package. So as it relates to optimized discharge processes, things like effective medication reconciliation, discharge education and prep, making timely referrals to all levels of services for support, effective care transitions to the next site of care, and deploying patient and family engagement strategies within the discharge planning process. The second is policy and protocols, policies and protocols specific for screening, management, discharge and referrals, and also for transfers and follow-up with that patient. We know that we often move these folks around, so it's important that we close the loop. Policy and protocol also, or a checklist, for example, for clinical documentation into our EHR. The third primary driver is staff education. This is one that I know that there's a tremendous amount of resources in the resource package for basic behavioral health education for our med-surg workforce. We really recognize that, although we'd love to get these folks to specialized beds where we are realistically sometimes managing them in our acute care environments in rural settings. And so we need to really equip our nursing team and our med-surg units with some basic tools to meet the needs of these folks. And I think Steve talked about a lot of things that can be adapted and implemented to normal acute care environments. Screening, education tools, and also managing crisis de-escalation, as Steve talked about. Lastly, partnerships. These things are, for example, service agreements with community primary care providers or integrated practices, outpatient and community health services, your local substance and alcohol abuse centers. And we need to have agreements in place that reflect the goals of the medical, surgical, and behavioral health integration. We really need to consider what opportunities are available in regards to telemedicine and also transfer agreements. So I hope that gives you a little bit of an idea of what the new resources is. Here's where you can find it. As I mentioned, it's located on Innovation. We've included it in the materials for this session. It can be downloaded free of charge at Healthcare Communities webpage, or certainly you can contact a member of the Compass HIIN team and we'd be happy to help connect you with the PDF version. I'd really encourage you to take a look at this document and see if there's tools and resources in there that you all might be able to use to help sort of meet the needs of your behavioral health and substance abuse patients as it pertains to your med-surg units, and certainly through the lens of reducing readmissions. So just circling back to our questions to run on, Do you consider patients with behavioral health conditions or substance abuse to be at risk for readmission? I think many of us do. And what resources do you currently have, both for those patients and also for your staff? And so I see that Katie Fodenhauer with our education team has pasted in the link to healthcare communities, and we'll be sure to include this PDF document in our follow-up materials. Being cognizant of the time, I'm going to go ahead and just move ahead to some closing remarks for today. We know that it's a long morning at the or at your computer when we do these virtual learning communities, but we do appreciate the opportunity to bring you virtual education that hopefully will support the goals of the HIIN and also of your quality teams locally. We hope that you've heard something that you can bring to action and moving forward. We welcome your ideas for future education as we move into next year, and we'd really love to hear how we can support you moving forward into 2019. We'd encourage you to reach out to a member of the Compass HIIN team or your clinical quality consultant with your suggestions and ideas. We want to wish you a wonderful Christmas holiday, and of course, thank you for all that you do for the network and for your patients each and every day. Thank you so much for joining us. We hope that you'll take a few moments to complete the evaluation that you'll be receiving via email. Thank you and have a great day.